Welcome to MedBridge Live Webinars, your source for live CEUs with industry-leading professionals. Before we begin, let's take a moment to look at the webinar interface to ensure you get the most out of this course. For the best experience, we recommend viewing this webinar in a full-screen window. In the upper right corner of this page, you'll see the Webinar Slides window. These slides will advance along with the webinar. If you'd like a copy of the slides to refer to during the webinar, you can download the course materials from the Resource List window at the bottom of the page. These materials can be downloaded at any time throughout the webinar. Throughout the webinar, there may be opportunities to participate in poll questions. Polls also appear in the Webinar Slides window on the upper right side of the page. To submit your answer for the poll question, select your answer choice and click Submit. After all the answers have been collected, the results will be presented in the Webinar Slides window. We encourage you to submit questions at any time during the webinar in the Q&A window, located in the lower right. Please use this window to submit questions related to the webinar content. Questions will be answered during a Q&A session at the end of the course. At the bottom of your screen, you can find icons for each window. If at any time you can't find a window you're looking for, click the corresponding icon to bring it back into view. For MedBridge questions related to this webinar, click the MedBridge icon and you'll be directed to our support page. At this page, you'll find tips and tricks, as well as contact information for our support team. For help with any technical difficulties with the ON24 platform, please click the wrench icon. Please review your accreditation per state and discipline. You can find this information on the webinar details page where you registered for this course. Remember, you must be present for the full duration of this webinar to receive CEU credit. After the webinar has concluded, you must also complete both the webinar quiz and participant survey found in your MedBridge dashboard within 7 days. If you have any questions regarding accreditation, please contact MedBridge support. Thank you for joining us today for this MedBridge Live webinar. We hope you enjoy this presentation.
Welcome to our first Hand Therapy Symposium. My name is Ann Pareto-Lurkey, and I will be moderating the event today. One of my role models is Don Newman, and in his book, Kinesiology of the Musculoskeletal System, he begins with a profound statement: to those whose lives have been strengthened by the struggle and joy of learning. This truly embodies the spirit of our profession, our understanding of biomechanical principles, and the nuances of treating specific diagnoses come from countless hours of study, practice, and yes, even struggle. Each one of you who's here today has made the choice to continue on this path of professional growth, both for your own development and for the benefit of your patients. This commitment to ongoing learning and improvement is not only a reflection of your dedication to your craft, but also a promise to provide the best care possible for those who depend on us. Today, as we gather for our very first Hand Therapy Symposium, we have a unique opportunity to learn from some of the brightest minds in our field. These experts are here to share their knowledge, experience, and insights with us, helping to further advance our hand therapy specialty. Thank you all for being a part of this important event. Your presence here is a testament to your dedication, and I'm excited for the valuable discussions, discoveries, and connections we will share throughout the day. Let's make this symposium a true milestone in our continued journey of learning and growth. Just a couple of reminders. There are 2 sessions for the summit. The second session is titled Part 2, Hand Therapy Virtual Symposium. To be eligible for CEU credit, participants must register, attend, and complete both parts of the Hand Therapy Virtual Symposium in full. Additionally, participants are required to complete a learning quiz and a post-webinar survey, both of which will become available after attending both parts. Partial credit won't be given. The link to register for Part 2 of 2 Hand Therapy Virtual Symposium can be found in the resource section of Part 1 Webinar Console. And now we will begin with our first speaker.
Thank you, Ann. I'm Nora Barrett. I'm an OT, a certified hand therapist, and I am wound care certified. I'm going to begin today with our first course, which is Wound Care Essentials for the Hand Therapist. The learning objectives today, we're going to talk through some wound healing principles. We're going to talk through wound cleansing. We're going to talk through wound care strategies that definitely include debridement, kind of recognizing debridement when it's necessary and why that's so important. And then we'll talk through some topicals and supplies. That's usually the most common question I get is, what to put on this wound. So this model today is a great format. I think we're going to talk through basic principles and kind of what I think every hand therapist should know about wound care in the first chapter. And then I'm going to take you through two cases that came to me as a regular certified hand therapist, not necessarily as a wound specialist. So this is my top 5 tips for wound care in the hand clinic. We're going to talk through wound cleansing. What is it and what do I use? Debridement, again, why it's so important to get rid of those dead cells. We're going to talk through the moist wound environment principle and why that is so important to not let a wound dry out. We're going to talk through topicals, things that might be in your clinic or you might have access to and when to use them. And then we're going to talk about dressings, right? Not only to meet the needs of the wound, right? What do I put on it to help the wound heal, but also what's best for the patient. And that's a very common point I try to make, is that it's not always about what the wound is showing, or it's not just about what the wound is showing. It's what's going to be easiest and best for the patient and or the caregiver to manage. So wound cleansing. The number one rule I always tell folks is that soap and running water are appropriate for most hand wounds, and that happens between each dressing change. One of the most common things I hear is people take off a dressing and then just put a new one back on. You actually want the patient to wash with soap and water. This includes postoperative incisions, staples, sutures after 48 hours, and after that post-op dressing takedown. So incisions, staples, sutures can all be washed with passing or running water and soap. You never want to soak, and that's that bottom point that says avoid soaks, because if a person puts an open wound into sitting water, bacteria lives on any skin, including a wound. Bacteria can enter the water and then re-enter the wound. And so that's why we say water that's passing by. So when is it not appropriate to use soap and water for hand wounds? Full thickness injuries, injuries with a deep defect, or dead space is what we call it. Anytime there's debris in the wound, or if we know that there's infection or we suspect it, in that case, a cleanser is going to be a better option. So those scenarios are when you'd want to use a cleanser, not just soap and water. And again, we would avoid soaking, meaning putting the hand into sitting water. So ideal cleansers, what are we looking for? Hypochlorous acid is the named key ingredient in antimicrobial cleansers. There are 2 commercial cleansers on the market that contain hypochlorous acid. It's ideal because it's effective against infection. It kills infection. It's effective in breaking up biofilm, which essentially is kind of like a film layer over a wound that's not otherwise visible, that is known or assumed to be in kind of hard to heal, or what we used to term chronic wounds that will not heal. That action of mechanical cleansing or wiping down with hypochlorous acid has been shown to actually break up biofilm. Hypochlorous acid is also non-cytotoxic to healthy cells, so it won't kill those good cells that we need to continue the wound healing process, the macrophages, the fibroblasts, all those cells. We don't want to kill those too while we're killing infection. And the pH in hypochlorous acid is also similar to skin, so it's not as irritating. It doesn't take as long for the skin to recover from cleansing. So what do we avoid? These are all common things I'm sure that you've seen in a clinic or in a hand surgery office. Dilute sodium hypochlorite solution, otherwise known as bleach, is like your Dakin solution. Acetic acid has been shown and known to be effective against Pseudomonas, but it's not compounded for commercial availability. Povidone iodine is also known as betadine. And then chlorhexidine gluconate, which is your Scrubstat and your Hibiclens. All of those products kill infection, but they kill everything, right? So they're cytotoxic to those healthy good cells. And that's why we don't want to use them in an ideal scenario. If you've got a patient who has a known infection and this is all you have your hands on, then okay, when the primary purpose is to kill infection, but just know that you're also killing good cells. Hydrogen peroxide sits at the bottom by itself because it is cytotoxic to healthy cells, but it also doesn't kill infection. So that one is an absolute no to me, whereas the top ones you really want to avoid in an ideal scenario. But if you have infection and have nothing else and your patient cannot get their hands on anything else, that would be appropriate to use to kill infection. So number 2 is debridement. The definition of debridement is removal of dead, devitalized, contaminated, any foreign material. If it's dead, you want to get rid of it. Get it out of there. It can be either mechanical or Sharps conservative. There are other types of debridement, but as a hand therapist, these are the two most common that you would use. Mechanical debridement is a gentle scrubbing or wiping material away from the wound bed, not aggressively, but to the point where you are removing anything that's softened ideally. So the best scenario would be to actually have that material softened, not dry, because then it's painful and it is disruptive to the healing skin. The other type of debridement we use is Sharps conservative, which is when you would use scissors and forceps, and that's how you'd want to document it, that you were using Sharps debridement, because then it is actually a code that you can charge for. As a CHT, you are absolutely able to do Sharps conservative debridement. If you are a PT, you can do Sharps conservative debridement, and if you're an OT without a CHT, it's state dependent. So, removal of necrotic tissue from the wound bed, why do we do it? And why is it so important? And why do we need to recognize when it needs to be done? It decreases the likelihood of deep or surrounding infection. It helps to speed the wound healing process. You're getting all of this dead debris that's stealing the nutrient and oxygenation supply. So you're removing that. So now you're restoring and facilitating that nutrient and oxygen supply to those good cells that need those materials in order to heal. And it can transition that non-healing wound to a healing trajectory. This photo is a gentleman who had a severe crush injury. You can tell the index finger has been literally amputated and put back on, but not exactly in a great position because of the deformity. But that middle finger is what I want you to pay attention to. Look how dark and black that is. Our surgeon was absolutely sure she was going to have to amputate, and then just in one Sharps conservative debridement sitting at a hand therapy session, that middle finger basically went from the top picture to the bottom picture. So important to get that dead tissue out of there. Debridement is considered a standard of care. It removes necrotic tissue, which is dead tissue, senescent cells, which are not infectious, but they're just not doing anything. They're kind of old and sitting around and kind of lazy, so to speak, and then that biofilm as well. Debridement also decreases bacterial bioburden. So basically that's the level of bacteria in the wound and in the skin. And so anytime you can decrease that, that's so important, so that you're not moving towards that infection level. All of us have bacteria on our skin. The problem is when it becomes symptomatic, right? When it starts to invade the immune system. Debridement also exposes capillary endothelium, so inner lining of those blood vessels, to help reinitiate that healing cascade. That's so important, especially when you've got a wound that's kind of stalled and not moving through the inflammatory phase correctly. So because of that, we now say that pinprick bleeding is considered acceptable with debridement. You know, we used to say do not cause anything to bleed, and now it's actually approved in the wound world that pinprick bleeding after debridement is considered acceptable because you're reinitiating that healing cascade. And debridement also facilitates healing via granulation, which is the body's way of forming new tissue with a deep, full thickness wound. And that what we call epithelial edge migration, which is those epithelial cells at the border coming together to finally close off a wound. So a moist wound environment. Dr. Winter, who is a PhD wound specialist, did an experiment in the 1960s that basically taught us that moist wounds heal faster. So he intentionally made wounds on the back of pigs because their skin is similar to ours. And then he covered one with a thin polyurethane dressing and then left one side open to air in multiple amounts. And basically what he found was those with the thin polyurethane dressing healed faster and better quality skin. And so since then, we've known that moist wounds heal fast, yet I still have people come in and say, oh, you know, so-and-so told me to just let it dry out. So it's so important not to do that. A moist wound environment helps to promote hydration and cell function. All of those tissue healing phases, hemostasis, inflammation, proliferation, maturation, are all very dependent on moisture in that moist wound environment. A moist wound environment enhances autolytic debridement. Autolytic debridement is the body's endogenous process to soften necrotic tissue so that we as therapists or as a patient can gently remove that at a dressing change. So most dressing options that we are focused on are trying to promote that autolytic debridement, which is extremely dependent on that moist wound environment. And then it also increases that re-epithelialization, that final layer of closure to get a wound to close, So that dry, crusted scab or tissue is a barrier to cell migration. Those little epithelial cells get to that scab and they stop. They're kind of lazy. They won't go past that scab. So it's important to not let those areas get dry or a scab form. You want to maintain moisture to allow that final closure. Clean and greasy is a concept that is promoted by Dr. Don Lalonde, which I'm sure many of you know from the wide awake flexor tendon surgery. He actually has several articles. They're listed there in your references. And he basically says that most wounds will heal as long as they're kept clean, so soap and water, and greasy, which is basically a petrolatum, right? A Vaseline, an Aquaphor, a white petroleum, whatever you have access to. So this includes that daily wash and water, soap and water wash, a petrolatum-based ointment, and then a clean but not necessarily sterile covering, just something to cover over that petrolatum to maintain the moisture, but also not to let the petrolatum get everywhere. And his big concept is don't let raw tissues dry and die. So this is a huge concept that we teach if you have access to nothing else, like this is the most basic thing you can have in your clinic, but also for those folks who go do mission trips to areas where there may not be as many resources. So topicals. One of the biggest things I like to go over is that antibiotic ointments should never be used for more than 2 weeks. That same antibiotic ointment should never be used. So this includes neomycins, antimicrobial impregnated gauzes. So this would be like your neosporins, your polysporins, your bacitracin, or your Zeroform with bismuth. And the reason why is because tissues develop an allergic reaction and they can build resistance to these products. So number one, you never want to use them until you suspect or have confirmed infection. And then number two, you don't want to use them for more than 2 weeks. But if you still need something that's an antimicrobial, after 2 weeks, you just want to change it up, right? Or I'll even say to folks like, use your polysporin for 2 weeks, then go to a non-antimicrobial ointment like a petrolatum, and then you can go back to it. But you don't want to go over that 2-week mark. And then that photo that you see is a patient with a crush injury with a significant soft tissue defect. He was using bacitracin longer than 2 weeks, and that's what his dressing looked like. So it actually looked like he was infected when truthfully he was just developing an allergic reaction to the bacitracin. All I did was change him to a petrolatum-based ointment, and then you can see the progression of how well he closed. It took 14 weeks, right? And that's, Dr. Lalonde will admit that this takes longer in these clean and greasy folks, but they're really moving towards this for fingertip amputations instead of some of those like fancier procedures that end up with, hook nail deformity or a DIP flexion contracture. So we're seeing more and more of folks who are just choosing to not have surgery for these deformities, which they could, or these defects, and instead let it heal on their own. And then finally, the last concept is dressings. What do I put on the wound is most commonly what I get asked. The biggest thing is we want to promote that moist wound healing, right? That helps to promote that autolytic debridement. We want to protect the wound from contaminants, right? We want to allow at least modified functional use of the hand. That's what's unique about us than probably anybody else who's working with wounds. And then we need to determine the needs of the wound, right? But also the patient. And so this is the photo series you see is a great example of a team working together. This gentleman had some psychosocial issues. He was legally blind. He kind of was known to be a picker of his wounds. He was living in a home that did not allow any wound care to happen. They don't do it. And so we basically came up with a scenario where I put him in an antimicrobial foam because I didn't like the color or the way that wound was looking, and it was deep. So the green one you see is the antimicrobial foam that's absorbent because he was producing some exudate. The pink one that you see is also a foam but not antimicrobial because that side actually looked okay. And then we actually put him into a cast. The cast tech came in, we put him into a cast in a functional position. He came back in a week, and in a week later that wound already looked that much better and he healed that well. And so those are scenarios where you're really taking the patient into account besides what the wound needs. One other thing I like to tell folks is that drainage drives dressing decisions. And basically what that means is if the wound is dry, you want to add moisture to it, but you never want to leave it open to air because that picture is exactly what happens. So the top photo is a young teenager baseball player who had a fingertip amputation, but there was way too much moisture, right? So we moved him to just a less moisturized dressing. He looked great. And then the physician said, oh, just let it open to air. And then it totally dried out. So you don't want to let it dry out. If it's dry, you want to add moisture. And then if it's wet and draining, you need something to absorb that exudate. So a foam that I mentioned would be like one example of one. And you want to avoid that wound getting macerated because even that massively macerated skin can also not heal as well, including also when it's totally dry. So you don't want the extremes, you want that middle balance, but you also still want to promote that moist wound environment. And then finally, to close out this chapter, dressing options need to meet the wound, but they also need to meet the patient's needs. So shared decision making and open discussions with the patient about proposed wound care regimens are integral to supporting patient adherence to management. And this is an example, this is a mother holding a child's fingertip. Fingertip injuries are my favorite example of you don't want to wash this every day, right? Who wants to change a pediatric fingertip injury dressing every day? No one. So this is an example of one of those dressings that would come in handy that stays in place for 4 to 7 days to help promote wound healing, and to not put the patient and the parents through that. So in summary, wound cleansing is an essential component of healing. It should be done each time a wound dressing is changed, but not necessarily daily if you're using a dressing that stays on for longer. Tissue that's dead or devitalized needs to be removed, debride it, get rid of it to allow that wound to heal more efficiently. Moist wound healing is considered best practice, and dressings are determined not only by the needs of the wound, but also the needs of the patient. So now let's go into a case. This is basically what I entitled, How Do I Care for This Wound? So this is a right hand dominant male in a professional career. He had a thumb pulp degloving with a nail bed injury and was taken to the operating room in February 23rd. The procedure was a first dorsal metacarpal artery flap to the thumb defect. And then because that flap was so in depth at the first dorsal metacarpal artery, he actually needed a full thickness skin graft to cover that flap donor. And so here's where you're going to see the photo. So this is about 2 to 3 weeks, but this is about 3 weeks later after surgery. So surgery was 2/23. Here he is on 3/12. Here's where the flap donor was, and then covering that thumb defect, dorsal aspect, as well as the volar aspect, which you can see on the right. You can see he's pinned at the MCP, and then this area here, that dorsal flap on the index finger, also now has a full thickness skin graft. So this is him coming out of the cast. You can see he's totally dry. There's a lot of debris in the wound. So what do I do, right? What's my first step? So my treatment priorities based on what I just saw and what I'm looking at is number 1, to cleanse, and number 2, to debride. So I'm going to cleanse the wound, the peri-wound, and the skin of that distal extremity, right? And that's basically what we're trying to do to make sure we don't have biofilm. And because of that debris in the wound, I'm going to use a cleanser, right? So I'm going to use a cleanser that's antimicrobial but not cytotoxic, so my hypochlorous acid. I'm going to avoid soaking, and then pin care, right? Pin care is always a big question in wound care and in hand therapy. So for pin care, you want to basically clean the pin with alcohol. You want to clean the skin with a cleanser or soap and water. And then you want to maintain that pin dry. You don't want to wrap little moistened gauze or impregnated gauze around the pin, because a pin is directly a straight line to bone. So you run the risk of infection or osteomyelitis. And then I also want to debride. So after I cleanse, I want to debride, which is going to look mechanical and Sharps conservative. So mechanical with moderate pressure. After I've softened that dead tissue, I want to gently wipe it away to make sure I can get anything removed easily. But then I'm also probably going to need to do Sharps conservative debridement, which is what I did need to do with him, using a scissors and forceps to remove that necrotic tissue. Bummer is I got so carried away, I forgot to take a photo. But I'm going to show you what it looks like next when he comes back in. You'll see what that looks like. So what dressing should be used for wound coverage? Based on tissue presentation, after I clean and debride it, those tissues were dry, so they needed moisture and some insulation. Foam is a great dressing to put on there. It can stay in place until the next visit, so it requires less work of him to have to do dressing changes, or whoever he's got at home. That thumb pulp contained deeper wound with necrotic tissue, and it also was draining seral purulent, which is kind of that thin, cloudy drainage. Doesn't automatically mean infection, but it means the body's definitely kind of moving towards that continuum. So in this case, I choose to use an antimicrobial, both a hydrogel to maintain moisture and to fill that defect, but then an antimicrobial foam that can help absorb, insulate, and then stay in place until the next visit. That skin that was surrounding the pin that was draining serous fluid, I'm going to use a foam, and I'm just going to put a little slit in it so I can put it around the pin, and then I can pull up that drainage but maintain a pin site dry. And so here he is when he comes back. So you saw a photo from about a week ago, a little over a week. So there's that fenestrated foam. I just put a little slit in that foam. It adheres to intact skin, but won't adhere to anything open. And then that green portion you see on the thumb pulp, that's the antimicrobial foam that's covering up the antimicrobial hydrogel on that deeper defect. This all looks great now, right? Dorsal hand looks great, but that index finger definitely still needs a little bit of debridement and a little bit of wound care. And then here's that thumb pulp, kind of much more zoomed in. So you can see that defect and you can see how necrotic that tissue is. Okay, so now what? That dorsal hand and web space are nearly healed. They look great. So I'm going to continue the foam over the open area of that index finger MCP joint where you saw that kind of debris that was still sitting there. And then I can change to a petrolatum-based ointment over the remainder of that skin that looks awesome. That only spot that needed a little bit was right in there in that index finger. So I'm still going to maintain my foam there, but everything else I'm just going to use a petrolatum. I'm still going to continue pin care with that fenestrated foam, which is again just a piece of cut foam and a little slit in it to slide into and around the pin site. And then I'm going to continue antimicrobial hydrogel and an antimicrobial foam for those deeper defects that have necrotic tissue so I can soften it and cover that thumb pulp area or fill in that area. I'm using those products. The hydrogel promotes autolytic debridement for endogenous removal of the necrotic tissue, and then the foam plus the hydrogel provides that moist wound healing environment that is safe from contaminants. So now here he comes in, you see him a couple days later. This is about a week later. So this is before I cleanse and debride, and sometimes it's subtle, and then the right photo is after. So you can just see little differences, kind of refashioning those edges, getting anything dead and senescent off of there. This looks pretty close and healed up now. I did get some of that necrotic tissue off the pulp and notice that his pin was pulled, right? So he's got that adhesive bandage there. Okay, and then here's the pulp. So same day, this is just the pulp that you can see still has necrotic tissue. The side view we've gotten a little bit off, but that area still is necrotic and is a deeper wound. So now dressing changes as that wound improves. That adhesive bandage can go over the pin site for about 24 hours, and then you can actually move to just a petrolatum-based ointment at the pin site. You're going to also continue with the petrolatum-based ointment over those closing dry areas. Anything that just looks kind of closed and healed but is dry, continue to use petrolatum. But then I'm also going to continue to that moist wound environment to promote an autolytic debridement for that thumb pulp. That thumb pulp with necrotic tissue is the deepest area and is having the hardest time closing. So I'm going to continue to use an antimicrobial foam and then a hydrogel if that tissue remains dry or has a defect in the space that kind of needs to be filled. Okay, so here we are now, again, about a week later, and you can see peeling has progressed even more. That dorsal web space looks great. Still that little thumb pulp that has some necrotic tissue. Dorsal thumb is looking pretty good, and then here's that pulp. Again, you see that kind of defect or step off, and so that's what we mean by filling that dead space, and hydrogel is a phenomenal product to use when it's dry. If it was draining or super, super wet, that's when we would use packing, and so that's the difference between using one of those products to fill that dead space, which is what you want to do to basically prevent an abscess. So ongoing dressing support is basically continuing moist wound healing and an autolytic debridement of that necrotic tissue at the pulp. So the drainage is no longer seropurulent and the skin color is healthy in the wound bed. It's still dry and still has open defect. So I'm basically just going to go from an antimicrobial foam and hydrogel to just a regular foam and regular hydrogel. And that's basically because now it's not looking toward infection, it doesn't have any odor to it, but I still need to fill that space and then cover and seal that off to promote healing. Okay, so here we are now about 2 weeks later, and we can spread these visits out further because he's doing well, closing, and we can give those materials. I can issue those materials or have them home delivered through an online agency that he can actually change that dressing, and those products can stay in place 4 to 7 days. So typically we just go 2 weeks, have him change it in a week. So here he is looking pretty good. That thumb pulp again is the only spot that's still taking longer to heal, but that necrotic tissue's gone. Okay, so now it's finally cleared. I'm still going to continue Sharps debridement to remove anything that's dead and devitalized, but because necrotic tissue is no longer present at that skin pulp, now I just need to maintain a moist environment and fill that defect. So I am going to continue to use the hydrogel and foam because of that defect. And then here he is now, again, in about another 2 weeks later. Dorsal web space is looking great. Dorsal thumb is looking good. And now that right thumb pulp is essentially closing and healing, but it's dry, right? So at this point, the pulp is filled in with granulation tissue, which is the goal. That's what you want. That outer tissue is dry and needs moisture, but there's no longer a space opening or defect. So in that scenario, I can just move to a petrolatum-based ointment or impregnated gauze, like a Vaseline gauze would be totally appropriate there, because the biggest thing is now it's filled in. You just need to maintain moisture, and you don't need an antimicrobial as well because the skin color looks good. It's not a concern for infection. Okay, and so here he is on his final visit with the physician, right? So if this is a scenario where his web space is tight, I need him in an orthotic, he's having trouble with any hand function or motion, then I'm bringing him back in to therapy. But this was the final visit with his physician, and you can see he definitely has some web space tightness, right? So this is a scenario where we basically then transferred him from routine follow-up with the physician to hand therapy. But he's pretty well closed. That thumb, because of the photo and the way it's taken, does look a little bit awkward, but it's closed there. It's just dry. So biggest thing there is basically maintaining moisture, opening up that web space, orthotics, and then moving him into function, right? So here he is with opposition, and then there he is with composite flexion and showing you, you can see the blanching in the skin, right? So you know that there's tightness, but he actually ended up with a very good functional result and was able to be back working in his career. So in this case, we would say that this gentleman had an excellent result after that FD, first dorsal metacarpal artery flap. It was about 10.5 weeks until closure following that surgical flap procedure. So I always kind of laugh when I'm at conferences and surgeons are talking about their ladder, the hierarchy ladder, and they're always enamored with the flaps and the high level procedures. And the bottom rung of those ladders, those reconstructive ladders, is wound care. But even these top fancy rung procedures still need bottom rung wound care, right? And that's typically what we as a hand therapist would end up with. Once that wound is completely closed, then I'm progressing to scar management, obviously orthotics if needed, sensibility retraining, functional use of hands, right? Range of motion and strength go without saying. And then that thumb pulp tissue will still need protection for a little bit longer until it's mature, right? That thumb pulp tissue, because of the depth of that injury, because of the flap that it required, is always going to be a little bit more of an issue as far as reopening, blistering, pressure sensation, right? Those types of things, especially with your workers going back. So there's a lot of education there about use of gloves for any sort of vibration, outdoor temperatures, use of tools. Those types of things are very, very important to cover with a patient because that thumb pulp tissue will have a higher risk of reopening or re-injury. So in summary, reconstructive surgeries require significant wound care, and it's typically the hand therapist that ends up with this, right? Even for some of those debridement photos that you saw, or some of those really dry, dead photos that required debridement, the surgeon sees them in the clinic for follow-up, and they just get sent over to hand therapy, right? So it's worth a conversation in your clinic. If you are not comfortable with debridement or you have not done it before, it's not something that's discussed or talked about, it's worth having a conversation who's going to do the debridement because it requires time, right? It's a timely event. It's also reimbursable as a CHT, so it's worth that conversation to talk about debridement and who's going to do it. The wound presentation and the assessment of the tissues are what drive dressing options. That first photo that you saw with that totally dry, dead debris coming out of the cast, the physician, I kind of laughed, sent the prescription down and said, wound care and, what should we put on this? And truthfully, my answer is, I don't know yet. I've got to debride and see what's happening. I've got to get rid of that dead stuff before I can make any decision about what type of dressing is going to go on there. Your dressing options will change as the wound bed characteristics change and as wound healing occurs. And that's what should happen, right? If you're using the same dressing for weeks and months at a time, especially in a hand injury, that's not normal, right? That means that something's not progressing. So you should see this gradual lessening, or what we say debulking, right, of that dressing. That means wound is healing, and that's what we're looking for. That's appropriate. And then dressings that remain in place for 7 to 10 days can be less stressful for the patient and caregiver and promote an undisturbed wound healing environment. So that's where a lot of these newer dressings and newer technology were born, to not have to put the patient through a dressing change and to allow that wound environment to be undisturbed. And so that's where we can justify some of those dressings that, yes, are more expensive. But there are services. There are 2 known services that are home delivery. I do have to fill out a form that says wound bed characteristics and measurements and all those things, but then we can actually send it through home delivery and they take care of insurance needs. So that's always a common question I get too, is like, where do you get all these products and supplies? You should know them because we can get them delivered and covered by insurance, but you should also know them because patients have availability now. They're all over Amazon. They're at CVS when you walk in now. So you should know what a lot of these dressings are because patients now have access to them and they're going to ask you. Okay, and then finally, let's take another case, and I entitled this one, "What Should I Put on This Wound?" So this is the final case in my course. So this is a male in his early 20s, extremely active, both at work and then outdoorsman. He is right hand dominant. He injured his right hand. This was actually a rollover motorcycle road rash case in July. So we see this a lot in the summer with folks who are not wearing gloves and then have some sort of injury or rollover with ATVs, bicycles, e-bikes is another big one. So we're seeing a lot more of these injuries. And of note, he's a carpenter, right? So super, super right hand dominant, very aggressive and active with his hands. So he had a debridement and a washout in the ED. This is the initial picture of what it looked like. I've not met him yet at this point. And then this is his first visit to the hand center for a wound check. So I essentially work with 2 days a week. I work with surgeons and they see the patient and then send them over to hand therapy for whatever it is they need, right? Wound care, an orthotic, exercises. And then 2 days a week, I actually see scheduled patients and outpatient. So for a lot of these folks, I was seeing them for wound care. And then what we ended up doing, if they didn't need physician care anymore, is I would just put them on my schedule, or colleagues too. My colleagues have most definitely taken to doing a bit more wound care. When I first started working in my current scenario, there wasn't a lot of wounds. And I was like, this is interesting. And then once I started looking for them, I started finding them and now they find me. But my coworkers are all pretty awesome as well. And I've done quite a bit to try to make sure everyone's comfortable with wound care. Because I think that's a big thing. If you don't see it often, it can be very overwhelming. And so I'm hoping that these cases and that the initial chapter are helpful with kind of basic concept of what you need to know to help these folks. So the wound bed is moist, right? So you can see that, right? There's not very much dryness at all. There's moisture, and there's a little bit of drainage by the time he's coming in. So again, he's almost 2 weeks out now from this injury. But please note this deep dorsal defect, right? Dorsal aspect of the hand over the index and then over the middle or kind of in between index and middle. Always be suspicious. When you have a deep dorsal defect, always be suspicious because of your extensor tendons, right? They live right underneath there. So even if you don't see them initially, when you've got dead tissue that needs to be basically debrided or maintained moisture for debridement, you absolutely need to make sure that you are protecting and acting as if those tendons will be exposed. They're high risk for tendon exposure. And looking at him too, he has no necrotic tissue, right? He's got pretty pink, healthy tissue. He's got some bleeding, which is all normal. So what do I do about this, right? What am I going to put on this? So hydrogel, right? I'm going to maintain that moist wound environment, which hydrogel is a great one for. If there was any more moisture, if it was draining what I would call moderate or excessive, then I wouldn't use hydrogel because now I'm going to add too much moisture. But hydrogel is a little more intuitive than a petrolatum. It basically kind of donates and adds moisture and it can actually absorb a little moisture too in the wound bed. So it's always appropriate for dry or minimally draining wounds. So that's going to fill that deep defect. It's also going to protect those potentially exposed extensor tendons, right? That's the key there. And then what do I need to do to keep that hydrogel in place? Hydrogel, unlike petrolatum, is kind of like jelly, right? If I just put it on my basic skin, it would roll right off. So it needs to sit into a defect and then it needs to be covered so it stays in place. So what I'm going to use here is a bordered foam. And by bordered, what I mean is there's basically a foam area in there that's absorptive, and then there's a little border that's non-adherent to anything that would be open, but it does adhere to intact skin. And that's how I can basically use that edge of intact skin to get that to seal in place. And then over that, I'm probably going to use something like a tuba grip compression, or maybe even an ACE wrap or Coban. So any of those are appropriate to hold that in place as well, especially because I know he's active. I'm never going to let him just walk out with just that. So that bordered foam is going to absorb drainage, it's going to maintain moisture, and can stay in place 4 to 7 days. This is a fellow who lives about an hour away. So here's his follow-up care, again, about a week later. Healing is progressing, right? He looks pretty stinking good, but if you look very closely on those ulnar aspects of both of those wounds, you can see extensor tendon, right? So that's what we were preventing, or basically trying to plan for. You can see granulation tissue, which is good, because granulation tissue is the body's way of healing that open defect, and it's your knowledge that, okay, this is healing, this is what should be happening. And you've got this epithelial tissue, this new tissue on the edges that's fragile and it needs protection, right? So what now? What am I going to put on this? So my dressing options, healing is progressing. So what I was doing before was hydrogel and foam and it was working. Don't mess with it, right? And that's kind of a golden rule of wound care. If what you're doing is working and it's working to heal the wound and it's closing, stick with it, right? Don't change anything. Extensor tendon is exposed, so hydrogel is considered the gold standard to maintain moisture. You don't want those extensor tendons to desiccate and die, right? Extremely important. Granulation tissue is present and epithelial tissue is present and it's fragile, so both of those need protection, right? That's what we want to fill that in. We need that. We need to maintain moisture so they stay healthy and active and continue that process. And then we want to protect that fragile tissue in the wound bed. So I'm going to continue to hydrogel into that extensor tendon in open space and a foam to cover it over, and then probably just a compression sleeve or something over that to protect him, knowing that he's active. So healing progression. Here he is, again, a little over a week later. The tendons are no longer exposed, which is awesome. But now you guys see this overlapping tissue that's almost literally kind of falling out of the wound bed. That's what we call hypergranulation tissue. Hypergranulation tissue is granulation, it's filled in, but now it's excessive. It's going beyond the border where it should, and so I have to treat that. So how do I do that? Silver nitrate, right? Silver nitrate is AgNO3, and that's what goes onto the granulation tissue. If I had a scenario where extensor tendon was still exposed, I would need to use hydrogel at the extensor tendon, but then I would use something like a petrolatum or a border before I put silver nitrate on, because I cannot have silver nitrate ever in contact with nerve or with tendon or any of those exposed structures. Okay, so in this scenario, we did not have to deal with that. Those tendons were now covered, but if they were, you'd have to be very, very careful using silver nitrate to not get it on the tendon or a nerve if that's in the scenario that's exposed. And then I'm going to use my foam dressing to, again, insulate and maintain that moist environment. I'm going to use compression as well as the silver nitrate. Compression also helps to mechanically push down hypergranulation tissue. So that combination of silver nitrate and hypergranulation tissue is what we use, and foam or compression is helpful to push down and mechanically that hypergranulation tissue. Okay, so here we are now with this nice progression. But what I want you to notice is here we are. So this is 8/26 is almost 2 months, right? And it's almost a month from the last photo. Now we're a month later at 9/26. You can definitely see the healing progression here. But now go from 9/26 to 11/1, right? What happened? Why is this taking so long in this young, active, healthy male? Right? So that's the main question, is what happened here that this is taking so long? That's not normal. And basically, what I would tell you is that he finally achieved closure on 11/28. This wound happened on 7/3, and it did close, but the reason it took so long is because in between those visits, and we put them much further apart once he was healing, he would say things to me like, oh, well, I just left it open, right? I needed to do blah, 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 or I was working as a carpenter, I didn't leave it open, or I went to use my hand and I kind of re-scraped it open. So the key here is you've got to educate these folks that they have to still cover it. Again, same concept as the last case. That wound was pretty deep. It is going to be so at higher risk for reopening, blistering, all of those kind of features, especially in a young active male worker. So those areas need protection. This is now closed, but it's dry. It has a higher risk of reopening, again, because of the depth and because it's the back of the hand. It's where it is, right? So what do we do about it? Your coverage options when it's dry is just a petrolatum and then like a tuba grip or compression to hold it in place. but it also needs protection. So a contact layer is a dressing that's designed to protect a fragile wound bed. It has a non-adherent surface to it. It's not like a foam where it absorbs. It doesn't absorb at all, but it's a great option for that pediatric fingertip injury that I showed you, just to kind of not let anything stick and cover over. They can stay in place for 4 to 7 days and protect that fragile wound bed. So in this scenario, if I was worried about him reaching into things and reopening that, I would use a contact layer over this surface and then a compression sleeve. If he wasn't active, let's say this was someone different who was an office worker and wasn't really doing anything to rub against that surface, then I would probably just go petrolatum and a compression sleeve. So you can use either one, you just wouldn't use both, right? Or this might be a scenario where I have him in a contact layer during the day because I know he's active and reaching into things, but then at night I would say, okay, take the contact layer off and just put some petrolatum on and then cover with a compression sleeve. So you can use either, it just depends on the moisture level and whichever's easiest for the patient to manage, but also is best for the scenario that that hand is going to be in. And then the compression sleeve can go over either. And I'm kind of trying, I know Ann is going to help with questions. You guys are putting in some awesome questions, but I just happened to see this one right next to me that says, what's the proper way to utilize silver nitrate? And so what you do is they come in sticks, and it's very particular in this little kind of tube they come in. It says open at this end. You always want to open it at the wooden end. You never want where the handle is, or the long stick. You never want to open it and touch the actual silver nitrate. I have done that several times, not taken it out, but gotten it on me after putting it on someone, and it will stain your skin, and it will stay, it doesn't hurt, but it stains your skin and it'll stay in place for like literally a week or longer. So you always take it out without touching that silver end. You always want to drop a small amount of saline on it to neutralize it. And I always kind of flick it like a cigarette to get that excess moisture off from the saline. And then you just gently roll it onto the wound bed. So for a wound that's that size, let's see. So for a wound that's this size, 1 would probably suffice, maybe 2. Any larger, I would probably go to 2 sticks. And so that's how you want to use it. Then you kind of dab it and let it sit a second before you put a wound dressing on. But it will stay discolored in that silver tone, usually for about 3-4 days. So that's a great question. Thank you. And then we'll get to questions. We've got an entire segment after I'm finished with this case for questions. So here in this scenario, he's closed, but he's just going to have a much higher chance of reopening, and that's super important to educate him on. Okay, so we talked through this. Dry as petrolatum. If it needs protection, contact layer, one the other, or a mixture of both, one at day, one at night, but never together. You don't want to put petrolatum on and then a contact layer, because then it's just going to slide off. Okay, but here's his functional outcome, right? Yes, I'm caring for his wounds, but at the end of the day, I'm a hand therapist. What I want is function of the hand. He has phenomenal flexion and extension, so huge save on those extensor tendons, right? And for the function and his ability to do his job. So in summary for this chapter, there's more often more than one option for wound coverage. There's never just one right answer, right? It depends on the wound, yes, but it absolutely depends on the patient. What's going to be best for them? Is it easiest to change it every day, or are they going to benefit from something that's a longer time frame that they can get back into your clinic and you can do it with them if it's overwhelming to them? Deeper wounds are going to require longer protection, especially since the risk of reopening is much higher for active workers and users, especially back of the hand. That's oftentimes what gets kind of scraped or bumped the most. And our job is to promote wound closure, but also to achieve functional hand use. So protecting those extensor tendons and being aware of that is really, really important. Okay, so in summary for the course, you want to cleanse, debride, get rid of that dead tissue, and cover, right? Those are your biggest concepts in wound care. Cleansing is necessary between each dressing change, because you don't want to just remove a dressing and put a new one back on. If you don't clean it, you're letting bacteria sit there, right? So cleansing is necessary between each dressing change, and what you use, soap and water versus a cleanser, is determined by debris in the wound, the depth of the wound, right? If it's an open big defect, you want to use a cleanser, and then infection. If an infection's present, same thing, you want to use a cleanser. Debridement is a standard of care and promotes efficient wound closure. So it should absolutely be a part of your practice if you're a hand therapist who is seeing wounds. Have a conversation with your physicians or your team if this is not something you're comfortable with. If it's not appropriate in your work setting, like you don't have the tools or the time or the space, those are important concepts, but it really, really needs to be done. Wound coverage should promote moist wound healing, right? Never let a wound dry out. And dressings are determined not only by the needs of the wound, but also the needs of the patient. Okay, so now we're going to get to our question and answer session. Anne will help moderate and get me some of these questions that you guys have been putting in.
Thank you so much, Nora. That was wonderful.
Sure.
So looking at some of the questions, we have some general questions. One, does clean and greasy apply to other wounds, not just the hands?
Yes. So Dr. Lalonde, actually, there's at least 2 articles that are written in your references and including on that slide. And he does argue that clean and greasy applies to all wounds. The only thing I would tell you that would be different would be something like a big abdominal open cavity wound, right? Those are scenarios where that's much more advanced. And as a hand therapist, you're not going to see that. But for anything like extremity-wise or surface injuries on the skin anywhere else, yes, clean and greasy is basically the way to go.
Okay, so what about the material that you use to wipe away the dead tissue? Is there something that's specific that you like to use?
There's a ton of fancy products out there, but mostly, folks, I'm using gauze, right? I'm just using gauze. Or if I'm using my hypochlorous acid solution, I will put it comes in a spray or in a pour bottle. We actually have it in our pharmacy. Our physicians can order it so our patients can pick it up to take home with them. It's actually very inexpensive. But what I'll do is I'll soak a gauze with the cleanser and then lay that down to soften that. So it's different than soaking, right? You're not putting a hand into sitting water, but I'll soak a gauze with a cleanser, put the gauze on for about 5 to 10 minutes of contact. That's what the literature says actually breaks up biofilm, and then to soften that tissue. But otherwise, yeah, just gauze. Or if a patient is at home, what I tell them for washing is a clean washcloth, a clean loofah. If they're nervous to let passing water hit their hand because it's really sensitive, which is totally appropriate, what I tell them to do is make sure the other hand is clean, let the uninjured hand take the water from the faucet and drip onto the injured hand, or lather up a clean cloth or loofah really well with soapy water, and then away from the water, squeeze it onto the hand with soapy water, then squeeze it onto the hand with just clean water if they're overwhelmed by cleaning.
So what about when a patient has a confirmed infection? Do they typically get an order from their doctor on which antibiotic ointment to use, or do you give that recommendation as a therapist?
So my biggest thing as a therapist is I go to the physician, I say, hey, I'm concerned about an infection, right? That's my number one rule is I am concerned about infection. And so then the physician typically will write the antibiotic. But I will tell you this, and I'm hoping you see more and more about this, there's a real movement to not prescribe antibiotics until you are suspicious of infection or you see signs of infection to actually let them go on an antibiotic. And the reason is because it's basically being called the next epidemic is overprescription of antibiotics that's forming what's called bacterial resistance, right? So that's when those antimicrobials, right, like your cleanser, your silver, your medical grade honey comes in all forms now, right? It comes in super absorbent alginates, it comes in foams, it comes in a paste. Those are all awesome examples, or that green foam you saw is antimicrobial. So there's not an antibiotic in there, but that helps to prevent infection. So when you just see that little bit of exudate that looks off color, or there's a little bit of an odor after you clean the wound, that's when I'm going to my antimicrobials, right? If I'm concerned about full-blown infection, the space is large, I'm measuring my wound space, it's larger, there's new open areas, there's a really foul smell, the discharge is gray, thick pus, that's infection, and that's when I'm going to my physician. They'll typically order an antibiotic, but you still want to use an antimicrobial because if there's a lot of thick, dead eschar and debris in the wound, an antibiotic cannot get to that healthy tissue. So you actually want both. You want an antibiotic and the antimicrobials in the scenarios of infection.
Thank you, because there was a question about Manuka honey, so thanks for answering that one.
Yeah. A great product, and patients know what it is, right? It's accessible everywhere now, and it comes in, like CVS makes their own brand, right? So it's out there, and it's affordable. So that's a great one to tell a patient to get if they're like calling into you because they live, an hour away, and there might be concern for infection. That's a total go-to for me, for them to purchase. And there's kind of you're not burning any bridges. There's no negative to it. If they use it and it's not infected, it's not going to harm them.
And that was a question in the resources, if we could have a list of brands and specific names of products like the petroleum-based ointment or the foam products.
Sure.
That was one thing people
petroleum-based ointment, Aquaphor, Vaseline, right? That's what we have. That's what I tell folks. For foams, there are many, many different kinds. I mean, there's so many now that it's actually overwhelming for even us wound care professionals to keep up with. But there are many of them. So I'm happy to make like a list, Anne, or something, and then send that out so it can go out to them.
That would be great. Thank you. So questions about, are doctors or nurses out of the loop on wound healing? I have a lot of patients that say their doctors want them to let their wound breathe and keep it dry. Is there a reason why they'd want that? And are the scenarios to keep the wound, there's specific scenarios where we want that wound uncovered?
So with all due respect, yes, they're totally out of the loop. Most of them haven't gotten any sort of education on wound care, or if they did, it was 25 years ago when they were told to keep it dry, right? I hear that all the time.
So Nora, when you came to our clinic last year and did a course, it was a tough conversation with some of our physicians.
For sure. And so that's what you've got a ton of references there for you guys. Take those references to your physician. Like, we now have great references that say hydrogen peroxide doesn't do anything. It doesn't kill, and it's cytotoxic. So we now thankfully have references. And so I started going, when I first started working at my current location, I just started going to my physicians with articles. I'm now at the point where I take the corner and they're like, do whatever you want to do. I'm like, well, hold on. Let me tell you what I'm going to do and why. They will admit that they don't know it. It's not covered in medical school at all. In fact, Dr. Lalonde, when I did a wound talk at AHS a couple of years ago, saw that I was giving a talk to therapists on the program, and he wrote me an email and he's like, why is this just for the therapists? The physicians need this more than anyone. So he's a huge proponent also of educating physicians and is very into the whole clean and greasy concept. So he and I and a couple other folks are actually on a panel together at the AHS meeting in Hawaii this January. So I'm excited for that, to just keep getting that message out. Don't let it dry out. And coverage. Coverage is another example too. If you've got an open wound, it has to be covered. If you leave it uncovered, the temperature drops so significantly that the wound can't heal. It needs some of that and that's what I mean by insulation. And sometimes that's just Aquaphor or Vaseline. That can be insulation. Cover it with a compression sleeve or a compression glove. A glove or a sleeve can go right over petrolatum. That's why it's beautiful, right? Is it going to get greasy? Yeah, have them get two, and wash and reuse. But those products definitely make it so easy because you do need a wound to be covered.
So this therapist is at a hospital-based clinic and they only have harsh antimicrobial hand soap. What kind of hand soap do you recommend when you're having the patients? Go ahead.
Best soaps, Dial and Dove, right? There's been many studies done on this, and the reason why is it's closest in pH to the skin, and it's not harmful. Ivory used to be on the list, and they changed their product. So Dial and Dove, those are the two I use. And if they have it in a bar, just lather it up really good and squeeze it on. Otherwise, just plain old liquid Dial like Gold soap.
And the question, it is okay to wash the wound 48 hours with the sutures in.
48 hours after initial post-op dressing takedown, right? So most folks are going to be in a post-operative dressing for 48 hours. Once that dressing comes down, the wound is totally appropriate to be washed with soap and water. And that's another big thing. Oftentimes they get sutures in and someone in the ER says, don't let it get wet, keep it dry. They show up to your clinic 10 days later and they're so dry. So that's a lot of, again, re-education. After 48 hours, and that's actually a CDC rule, after 48 hours, soap and passing water are completely safe and fine for wounds, incisions, staples, sutures, whatever it is.
So you mentioned to not apply Xeroform around pin sites, and one therapist is saying her surgeons place Xeroform around the finger external fixators.
So don't mind. Yeah, and so the reason we don't do that is because the main concept with wound care, and I will be super honest about this, there's been multiple systematic reviews about pin care. The problem is nothing's comparable because everyone's doing different things. So we don't have great data that came out of those that say this is not right. We shouldn't do this. But what we do have is a bunch of experts who came together in a consortium, wound care experts, and came up with what should be done. And so the main premise is pins themselves, the silver portion of the pin should be cleansed with alcohol. Okay, not the skin, the pin. The skin should be cleansed with either soap and water, saline, and I would argue if it looks raw, debris, or you're worried about infection, a cleanser, right? Totally appropriate. And then you want to keep that segment dry because the moisture in something like, Xeroform wrapped around the pins, moisture traveling down a pin site is the number one reason for infection. So I'm actually in the process right now, because our physicians were doing the same thing, right? Pins were getting wrapped in Xeroform and going into a cast for a week. And then it was getting redone when the cast got changed before the pins came out. I'm in the process right now of rewriting that. And what I'm going to try to get them to do is just go to a foam. A foam can absorb, it's dry, it can sit and protect the skin. And in scenarios where they don't need a foam because there's nothing draining, a gauze, right? Like just put a little slice into a 2x2 and put the gauze right underneath that pin. You want to maintain it dry. It should not be moist. Not great data, but that's basically what's been released by the Wound Care Education Institute, who basically put a bunch of leaders together to come up with that.
Okay, just a question with using mechanical debridement supplies. Do you use a new kit every time, or do you have cleansing solution for the scissors and tweezers to minimize waste?
Good question. So that's going to be very site dependent. For mechanical debridement, it's typically gauze, or if they're at home, it's their own products that they can launder. But for me, it's gauze that obviously gets used once and wiped away. For sharps debridement, for scissors and tweezers, container and they get thrown away, or they get autoclaved. So that will depend on your institution. Where I am currently, we do not autoclave. I'm sure they must have somehow figured it out. It's less expensive to get new product than to spend the time to autoclave and repackage. So we actually offer if you are comfortable with the patient, we actually offer the scissors and tweezers to the patient because it's single use, and then we throw it away. So oftentimes we'll tell them, like, if you're comfortable and it's softened and there's a piece of skin that you want to get off, don't rip it because it can reopen, but a gentle cut, or, if they're comfortable with it. Otherwise, we do throw them away. But they are definitely single use.
So there's a question about debridement. Are you giving pain interventions for debridement, and how does that process work?
So I don't give interventions for debridement. If I needed to, I can ask my physician to do a local, and I've only had that in the last 3 years in the hand clinic I'm working at now with the surgeons, one time with a fingertip injury for a gentleman who was in a car accident and was so hypersensitive, he could barely even tolerate like gentle washing. But for the most part, it's dead. The tissue is dead. So if you soften it, it is so much more comfortable for the patient. And then when you're pulling away, is dead tissue. So they're usually not feeling it. Now, taking out sutures, they'll feel it because you're pulling on the suture. You're pulling a tug on that string. That's what they feel. And they might feel the suture coming out. But removing dead tissue, it's dead. So for the most part, they're not feeling it, and I don't need to have them medicated. Only one time in the last 3 years have I seen that happen.
And they're so happy when you debrided it. They're like, wow, this looks amazing.
Totally. And sometimes they don't want to look. And I'm totally cool with that. But I do have them look after because the before and after is so impressive, right?
So on a clean, healthy incision that has dehisced after suture removal, what do you recommend for a dressing?
Great question. So here's an example to open the big Pandora's box. My facility was still stuck on wet to dry dressings, right? We've known for 25 years that wet to dry dressings is substandard care and should not be used. And you just heard me talk all about moist wound healing and moisture. If you listen to wet to dry, it tells you what's wrong with it. Wet to dry. It's allowing it to dry out. And then when you pull it off, you're reopening the wound, you're dispersing bacteria. Don't get me started. There's a million reasons why we don't do it. But that's what my facility was doing. And again, what I would call a reputable institution, in 2024, when we've known about this since 2002, these articles started coming out. So my favorite thing to do, Dr. Lalonde, clean and greasy, right? Mm-hmm. Have them wash it. Dehiscence doesn't automatically mean infection, but it means a higher risk of, right? There's a higher chance of infection with dehiscence. And dehiscence is basically an incision that's been brought together by sutures or staples that then just kind of gently reopens. It's extremely common. Sometimes it's due to moisture. Sometimes it's due to friction. Sometimes the patient's overusing their hand. Think about the dorsal aspect, how much that skin has to stretch. So it's a very common thing. Don't let them get super worked up about it, but clean and greasy. So oftentimes what I have them do is just wash with soap and water and then take a little bit of Aquaphor, as long as it's not super moist. If it's super moist, I might use something like an Adaptic, right? Or that oil emulsion impregnated gauze that's not going to lend more moisture. Something like a Vaseline gauze or a Xeroform has a ton of moisture. You don't want to then add that to it. So moisture level is going to determine it, but usually it's just clean and greasy.
So we have some questions. We have about 3 minutes left. We have a question from the case 1. So in that first case, how long from beginning to end, and was there no range of motion during that period? Are you performing range as you're working on their wound care?
Good question. So if this is somebody who needs a lot more than just wound care and basic range of motion exercises, here's what to do, and he's not following, that's when someone I'm absolutely either bringing back into my clinic for therapy, or if he lives far away, I'm making sure he is going to therapy near home. And that's a lot of what I do. I'm at a major university in the middle of central Virginia where we see folks from our region, and then we see folks, 4 hours away in Tennessee and as far out as Virginia Beach. So part of what I do is make sure that I've given them a prescription for therapy and a list of therapists that are near them, or I go onto the HTCC website to find them a therapist. If they're local to me, I am bringing them back in if they are not maintaining that range of motion. So part of what I'm doing besides wound care is I'm measuring that web space, right? That's my biggest concern. And then I'm looking at flexion. In his scenario, he actually did fine. He did great from a motion standpoint just by giving him a home exercise and an orthotic to maintain that web space. But if he wasn't, that's someone who would need to go to therapy.
So how long do you need to protect the flap? A therapist has a post-firework blast that developed a blister on the tip of his thumb amputation 5 months post-op from a Silipost gel cap.
Okay, so as far as protecting the flap, they're typically, depending on depth and where the flap was taken, if it's regional, they're viable in about 2 to 3 weeks. And so after that, you're pretty much wound care. You're careful with compression as well, just because of the vascular and neurovascular kind of connection and response. But scar, once the wound is closed, think of it from that time frame for 3 months. So for that first 3 months from closure until that 3-month mark, that's when you have the most influence over scar. So it may not need protection so much as at that point you're working on scar or using those gel-lined flaps or tubes. In my case scenario, his thumb was the deeper portion of the wound, and that's obviously what he's using for pressure and pinch. But I've seen him recently, and he does completely fine, but it's just more education on pressure and having that thumb covered, something, Coban, a glove, something, so the skin wasn't reopening.
Thank you so much, Nora. I'm sorry we couldn't get to all the questions, but we had some really good ones. And thank you so much for your amazing talk. And this is going to be so helpful, especially for those therapists that really don't do a whole lot of wound care. This increases their comfort level. So thank you so much.
Thank you so much. Thanks, everyone. Have a great one.
Good morning, everyone. Thank you so much for being here with me this morning. I wanted to thank MedBridge for having me here, and I wanted to thank all of you for spending your morning with me and allowing me to talk about a population that I'm very passionate about serving. And serving this population has multiple meanings for me, both on a personal and a professional level. So I'm happy and honored, and it is a very humbling experience to be part of the brachial plexus team with my employer to share the journey with these patients and clients. So thank you for having me, and I hope that you guys can take away a lot of things and utilize in the clinic if you have these patients right away. So just as an introduction, I'm going to go ahead and go to the next slide. Let's start with a little scenario. So it's Saturday, but let's say yesterday, Friday, it's been a very long week. Everyone's trying to get into therapy before their deductible is met. And you just did not have time to look at your schedule for Friday. Of course, there was a lot of traffic. You arrived to work a little late, and you didn't have a chance to review your schedule ahead of time. You get to the clinic running late, your first evaluation reads, status post SOMSAC procedure, evaluate and treat. The referral came from a center known for treating a lot of nerve transfers, but you do not have access to the operative note. What is your next step? Would you, A, quickly Google the SOMSAC procedure? Would you, B, phone a friend? C, call the MD office and ask for the protocol? D, you know what the SOMSAC procedure is, so you proceed with the evaluation. E, you reschedule the evaluation until you can get more information. Or F, you panic. So let's start with answering that and see where the audience is at. Okay, just a couple more seconds, and then we'll see where everyone's at, and that way I can kind of know where to focus on. All right. Okay, so it looks like majority, over half, said that they would call the MD office and ask for the protocol, which is great. Google is our friend. We can get so much quick information. And hopefully by the end of this, those lower percentages of those that have panicked or rescheduled or phoning a friend since we're already running late, hopefully you'll feel a lot more confident in that after this presentation. So the great thing about nerve transfers now is that there has been a lot of surgical advancements. And being part of the brachial plexus clinic, you know, this has really restored a lot of hope and function in some of the most devastating injuries. Now, although there are low-level studies on what is the best rehabilitation approach, there are 4 probably key articles that I'm going to review with you that if you do start seeing these patients or these clients, because you will start to see these a lot as the surgical advancements are being made, that would be worthwhile you reading. And although they are low levels, they are supply very, very important information that will give you the tools to feel confident with treating these clients. The great news is there's a lot of evolving literature that allows us to improve outcomes. Before I came to the center that I'm at now that performs a large number of nerve transfers, even coming from a level 1 trauma center, it was very, very few and far between in my 25-year career that I was seeing this. So yes, quantitative studies are wonderful and giving us some numbers on things, but really there are some really great qualitative studies specifically put out recently in 2023 by Dr. D and all at WashU that talks about what these people that are going through this, what they're going through this phenomenon. So what is it that they are experiencing, and what are we as therapists missing in their care? So qualitative studies provide very rich information for us as therapists that numbers just can't provide for us on how we can improve the quality of care. And then Brito in 2022 actually put out a study on what are the needs of the therapist, a qualitative study of what are the needs of the therapist. What are we lacking that to help us to support this population? And so I decided that I began to teach more and more on this subject because I wanted to meet those needs that came out of a lot of that qualitative study in terms of supporting other therapists and also upscaling on psychological and pain needs that were revealed in her qualitative study. The exciting thing is that the literature is evolving, and it really gives us as hand therapists an opportunity to demonstrate the distinct value that we bring to this population. So those key articles, I know all of you just have a ton of time to sit around and read articles, so I always try to provide kind of the best bang for your buck so that you can have some quick references. Starting with Kahn and Moore in 2016. Following that, you have Sturm et al., Hill et al., and Larosiri Salgado in 2021. Now, Kahn and Moore is coming out of the United States, where the other articles are coming from different countries. So those factors do need to be considered because obviously there are different healthcare systems. So let's quickly talk about some foundations of nerve rehabilitation and Kahn and Moore's article in 2016, which discusses the donor activation focused rehabilitation approach, or the DAFRA. And really, this is a model that recognizes those altered neural pathways that are created by the nerve transfer and really focuses on strengthening those pathways because ultimately we want to maximize functional outcomes. The DAFRA also talks and emphasizes the importance of cortical plasticity, knowing the surgical details, and having strong patient education. So when they discuss what are the factors that influence that return of function, I start the cortical plasticity because this is probably some of the things that I see therapists as well as the client struggle with the most and how to achieve this. But really, if that cortical plasticity doesn't happen, then the functional outcomes are not maximized. And then things that I think we're very, very comfortable with as well is exercise and positioning. So when we talk about phases of rehabilitation, just like we do with other diagnoses, for nerve transfers, we could see them in 3 different phases, which are also discussed in the DAFRA. And really, we can look at the basis of how we know that patient is going to move into the next phase is what their muscle grade is. So let's go ahead and take a look at those. So when we're looking at phase 1, this really is the preoperative phase, and also when the muscle grade of the recipient muscle is 0 out of 5. So we as therapists, what are our primary goals here? We want the client to be able to demonstrate that they know what the donor is and what the recipient is. Now, unless you're in a center where you are seeing a lot of these clients, or you're with the surgeons, sometimes you don't ideally see them preoperatively. Fortunately, because I'm in clinic with them, a lot of times I do get to see them preoperatively. If you are fortunate enough to see them, this is the opportunity for you to go ahead and take some baseline range of motion, meaning to make sure that their range of motion is supple and that what the strength is of the donor muscles. You can go ahead and use that time to really focus on teaching them how to activate the donor muscles before the surgery. And then, of course, just like we always do so well, we address joint limitations, muscle length, edema. One of our surgeons has a great saying of, we can help you move, but we can't make you loose. So that always sticks in their head a lot and with us, and we'll make sure that we carry that over, that unless their joints are supple and their muscle length is good and their edema is down, no matter if there is return, you won't increase your function. And then, of course, going into these appointments with these clients, sometimes there's a whole team of people. They could have 4 or 5 people in the room at the same time. It can be very, very overwhelming to learn what their options are, exactly what has happened. And some of these injuries, especially things like pan plexus injuries, are very devastating. So seeing them preoperatively allows them to gather themselves at home, any questions they or their family or support system may have, and we can answer questions at that time. So really in phase 1, we are focusing on flooding the donor. Now, we talked about the importance of corticoplasticity, and thankfully there is a lot of really recent great articles on the importance of this and why we need to focus on this throughout the rehabilitation process after nerve transfers. When we look at corticoplasticity, it's that brain's capability to adapt to all that motor and sensory input that's coming in. And it's an innate function of the central nervous system. And remember, our ability to adapt does occur throughout life. And the studies that are out there now on how to measure corticoplasticity, especially after nerve transfers, are those non-invasive techniques as listed here, which is transcranial magnetic stimulation, electroencephalography, functional MRI, structural MRI, and positron emission tomography. So then there's also a lot of really wonderful articles on neuroplasticity. And what this refers to is the central nervous system's ability to recognize and adapt to those internal changes or that environmental stimuli that's happening and how the system can optimize functional outcomes. Now, as we know as hand therapists, a lot of times with everything, that site of injury, what is effective, there's such a larger zone, right? That we see that all the time. It's no different with nerve transfers. So we are seeing changes at the brain and spinal cord level proximally and distally at the muscles and the effectors. So when we see differentiation or that loss of sensory input into the central nervous system, that causes the brain to reorganize. And after injury, those adjacent areas of the cortex start to invade those deafferrated zones. So really that nerve transfer is so that those deinnervated areas become more active in motor control and perception. So I wanted to point out some factors that help to determine outcomes of surgical nerve intervention that I think that are very important for therapists to understand and have realistic kind of expectations for this as well. Of course, there are some other factors that are talked a little bit more into detail that surgeons consider, but I kind of pulled out some of the ones if you're not familiar with treating these clients that are important to understand. So when making decisions on transfers, the donor and the recipient cortical areas are close to the motor cortex. The recovery of gross movements has greater success than in-hand manipulation tasks. Long-term outcome is dependent on the rehabilitation, and that we should start early. That is all listed in all the literature, and we must remember that this is not a short process, that it could be at least 2 years in duration, and that the outcome can depend on the age and the degree of injury, and that those with brain injuries can have decreased success. So what are the things and the techniques that we as therapists can do to address cortical reorganization? Well, we have graded motor imagery, the 3 stages of that. We have sensory reeducation, and we have bilateral movements. So a lot of questions that I get is, how often do we see them in this phase 1? Because there's nothing happening with the recipient. Well, just like a lot of things, it depends on a lot of factors. Less often if that client understands how to activate the donor, how to passively move the recipient. If their passive mobility is good, if their edema is decreased, and they're independent, and you see that they're able to perform those cortical reorganization techniques. You see them more often a lot of times because of the factors of someone having a TBI, insurance restrictions, they don't have a great support system, or they have decreased psychological status that doesn't allow them to carry over their home program. And then we also look at things like health literacy and self-efficacy. So a lot of times the greatest challenge of phase 1 is the waiting game. Thankfully, one of those key articles by Hill et al., it is a wonderful article for you to keep in the clinic. It has a table of 17 of the most common nerve transfers, and it has a table to keep everybody on the same page, that including using it to communicate with surgeons if those criteria are not met. So the table that is listed lists the nerve transfer, the indication for it, what the donor nerve is, what the recipient nerve is, the function that is going to be restored, how many months to muscle tenderness, how many months to a visible contraction, how many months to functional movement, and the percentage of patients that achieve useful motor function. So all that article encompasses a lot of questions that you may even have for the physician. So how do we know they're going into phase 2? Well, now we start to see a twitch in that recipient muscle. So if you have a question of whether that is happening or not, you can provide resistance to the donor, like an isometric contraction, while placing your hand on the recipient muscle to see, are you feeling any sort of twitch or tenderness? Now in phase 2, our goal switches from flooding the donor to now flooding the recipient. What are our options for this phase? Well, we continue to activate the donor, but now we can move to gravity-eliminated exercises for the recipient. We continue cortical reorganization, and if you have access to a biofeedback machine, this is the time where you can start biofeedback to the recipient. If you're unfamiliar how to use it, thankfully, Sturm et al. In 2019 provided an article on the use of biofeedback in nerve transfer clients. Then once they're able to achieve more than 50% in gravity eliminated position, then we could start a place and hold with the recipient. And then once they can go against gravity, we could start to work on what's called selective activation, which is where they will be able to activate the recipient without activating the donor. So then going on, they've now been able to move against gravity. Now they're ready to go on to phase 3. And here our primary goal is to relearn that original movement pattern. And we have options here, which I think a lot of people feel very comfortable with after they've been able to move against gravity. Again, cortical reorganization happens. If you have a biofeedback machine, you can use 2 channels for that selective activation, where they will quiet the donor and activate the recipient only. We want to focus on low intensity training and start and always include occupation-based and meaningful activities. So the hand therapy field has adopted the ICF, which moves away from the medical model and takes a biopsychosocial approach to those that have sustained upper extremity injuries. What this does, it gives us a common language to communicate with all stakeholders on how there's more than just a physical aspect that affects a lot of these clients, if not all of them. So what has been looked at is some assessment tools that are listed here, the brachial assessment tool, and then the impact of brachial plexus injury questionnaire. And if we look at some of those things like the environmental and personal factors, revealing from some of the qualitative studies, these are the areas that therapists struggle with a little bit more, the psychological and pain, addressing that. So what I did was also put in some references on how to assess psychological factors. And this is great because Hamaski's article talks about the different types of psychological factors and then provides assessment tools. So if you're noticing that your clients are experiencing any of these, you have assessment tools that allow you to have some outcome measures and see how effective your treatments are. Also includes the emotional factors as well as some assessment tools here. Again, a lot of times we'll use this when we're communicating with the physicians or with case managers or insurances as well for making appropriate referrals if they need it outside of occupational or physical therapy. Now, these are 3 key articles that I always try to give to any of my students or other therapists that ask on how can I address psychological factors. Probably one of the best articles is the middle article that I've read, and I've actually taken this article and reviewed this with our hand surgeons and hand surgery fellows, what really talks a lot about not only recognizing cues that our clients are having, but how can we react and what can we do different as healthcare providers to address some of the psychological factors that we're seeing in treatment. So in summary, when rehabilitating nerve transfer clients, communication with the surgeon is essential. We talked about the principles of the DAFRA and that there are 3 phases that are based on the muscle grade of the recipient muscle. Remember, the frequency of the visits vary throughout that rehabilitation process. So although I provided some guidelines, really individualize each according to what your client presents with. It's essential to take a holistic view and address all aspects of the client to align with the ICF and to maximize your outcomes, and really hit cortical reorganization throughout the phases to optimize those outcomes. So now that we've gone through some of the foundations, let's talk and apply them to some procedures. So we talked about the SOMSAC procedure. So when we talked about those 4 key articles, before we talk and apply some of these concepts, this kind of outlines the differences between the articles. Based on the DAFRA, you could see they each have different detailed things to work on, and the phases are described a little differently. But if I had to synthesize those 4 articles, there are some similarities, which all of them include early involvement of rehabilitation. They all recognize that cortical reorganization is essential. The progression of the program, the criteria is the same. Where the differences lie is that the use and the timing of graded motor imagery, and also whether or not just mirror therapy or visual imagery is used. What differs is the suggestions of methods on early education. Some use NMES and biofeedback differently, and what type of equipment is used. And then also articles differ a little bit on the details of each stage. So this is available for handout. All those things that we talked about are summarized here depending on the muscle grade. So although these are guidelines, just remember, time frame varies, the importance of communicating, always monitor psychological status, and that benefits. You see these clients for a long time, at minimum 2 to 3 years on and off. So when we talk about the SOMSAC procedure, these are some of the things that we're taking out of the Hill article in terms of what the indications are, what the donor nerve is, which is the long or the medial head of the triceps, and the recipient nerve being the axillary nerve, and we're trying to restore shoulder abduction. Okay, so let's look here. Which of the following should you measure when at this, say you get a SOMSAC procedure, their first postoperative visit to therapy? Let's say the client is 3 weeks out. Would you A, measure the client's passive mobility of the shoulder and elbow. B, the muscle grade of the deltoid. C, the client's ability to understand the donor and recipient. D, the client's active range of motion of shoulder flexion and abduction. E, all of the above, or F, A, and C. So based on the concepts, what would you do at the first visit? Great, we're almost there, perfect. Okay. Great. Okay, so over 50% got that correct. Great. So let's go through that and see where kind of fall in that. Okay, so if we're looking at the SOMSAC procedure, we're looking phase one, we're activating elbow extension, we're passively doing shoulder abduction, again, doing cortical reorganization and emphasizing that patient education. Remember, we are now, our goal during phase one is we are flooding the tricep. So let's look at ways to activate the active tricep passive recipient. Okay, so here we go. We're looking at using a bar. Here he's doing active tricep extension and then passively using the bar to do shoulder abduction. Great. Okay, here is a video of using a Swiss ball, active tricep, and then passively going into shoulder abduction with the ball.
Okay, straighten the elbow, use your other arm.
And then another option is you can use pulleys where you're doing active extension
Lower it back down.
and then passively going into abduction.
Good. Straighten and then move it out.
So those are just some options for you. And here they can do seated with a Swiss ball as well. So giving a couple of options there. So now let's say you start to notice a twitch in the deltoid, or if you're questioning it, resist tricep extension isometrically and palpate the deltoid. Now you could start gravity assisted exercises for that deltoid, and this is when you can start doing biofeedback to the deltoid. So remember now our shift goes from flooding the tricep to flooding the deltoid. Now once the client is able to achieve over half range of motion in a gravity limited position, you could start doing place and holds to the deltoids. And then once they can now raise it against gravity, you can work on that selective activation. Okay, so let's look at some of the gravity, hold. That's one option. Again, he's pressing, going out, lifting off, and doing a place and hold here. You can also do it with the bar. They can release and try to hold that there. Come back. Great. Just a couple of options there. Okay, so then now they can start to go against gravity. You know you're ready to go into phase 3. We could start to make sure that they can activate the deltoid without extending the tricep. We will do a low intensity strengthening and then relearning those normal movement patterns. Again, occupation and meaningful activities. The biggest thing here is really looking for compensatory patterns, because remember, it's been months since they've been able to activate that shoulder and they've compensated in a lot of ways. So here we focus on low intensity strengthening, again, selective activation, and that return to meaningful occupations. So in summary, the SOMSAC procedure is used to gain shoulder function. Remember, the interventions for each phase depend on the muscle grade, and it could take months till you see any functional use. So we constantly are looking for compensatory patterns. So now let's look at the modified double Oberlin procedure. Again, looking at that Hills article, our donor nerves are the FCU fascicle of the ulnar nerve or the median nerve. The recipient nerve we're looking for is a motor branch to the biceps or the brachialis, and then we're looking to restore elbow flexion. So if we look at phase 1, we're teaching them again, active donor, which is fisting and wrist flexion, passive recipient, elbow flexion, working on that cortical reorganization and patient education. So let's start with this. What would indicate that your client is ready to move on to phase 2 in, let's say, the modified double Oberlin procedure? A, the client is able to understand the donor and recipient. B, the client is able to raise their arm overhead. C, there's a twitch noted in the bicep. D, the client has full passive flexion, elbow flexion. So how do we know they're ready to go to phase 2? Okay, let's look at the answers here. Yay, yes, a twitch is noted in the bicep. All right, so now the twitch is here. So now, again, if we had a question of whether or not that was happening, we would resist wrist flexion and put our other hand on the biceps and the brachialis. They're ready for gravity-assisted exercises to those muscles, and you can also start biofeedback. So now our intervention and our focus is now to flood the biceps and the brachialis. For the recipient, again, we can start progressing them to place and hold, and then start selective activation once they can move against gravity. And then I'm going to show some examples of that. So using a towel and the other arm to assist on a slick surface. They can just do it standing. Here is just after they are able to perform a place and hold. And if you have things like an arm skate, or at their gym, if they're a really active person, they have these ab roller things that they can use. Again, it's really finding about what does that client's day look like? What do they have available to them? And getting creative. That's what we're the best at. So as long as you know what movement you're looking for and your goal, you can modify it. So then they start to go against gravity. Now they are ready to move on to phase 3. So we're now going to start to have them to activate the bicep without having to flex their fingers and curl the wrist, work on low intensity strengthening, and then also relearning normal movement patterns with their daily occupations. Our focus again is on low intensity strengthening, activating that elbow without flexing the wrist and fingers, watching for those compensatory patterns, and doing things that are meaningful for them. So if we looked at what we just summarized here, the double modified Oberlin is performed to gain elbow flexion. The Songsak is performed to gain shoulder function. So it is important for us to go ahead and monitor for those psychological and psychosocial impairments throughout the process. When I talked about the qualitative studies earlier from D et al. In 2023, the importance of social support, social participation, how the uncertainty of these injuries is very frustrating to the client, and sometimes that they feel left out of the decision making. That has really changed my practice, at least knowing that maybe I didn't know that this is what this population is going through, and those are things that I need to bring up as a therapist to make sure they're addressed. And remember about the cortical reorganization, to really hit that at every phase. And of course, just like we do with everybody, make each treatment session meaningful, efficient, and effective.
Thank you so much, Jen. That was great. We'd like to go over some questions. There was quite a few questions on cortical reorganization, but before we jump into that, there was just a general question, and maybe this is something you can answer. It's more from a surgeon's perspective, but how is a surgeon choosing a nerve transfer versus a tendon transfer?
Yes, so that is a very great question. A lot of times, just like in the articles, getting these clients to a therapist in a timely manner is essential. So is getting those injuries to a surgeon. Also, it is time sensitive. Ideally, they like to see these clients earlier than later. So let's say within 6 months, because they do have time frames that the nerve transfer will not be nearly as successful. Now, tendon transfers can be performed at any time. So that's probably the biggest difference, is it is a time-sensitive manner. And I have found as time has gone on, sometimes that length has sometimes somewhat increased a little bit, but it really, the sooner you can get them between that 6 months, 9 months would be ideal. Where tendon transfers, there's no time limit.
What do you feel like is it like after 1 year? Is that really then now they're looking at tendon transfers versus nerve transfers, or is that what's the maximum time frame, at least what in your experience?
Yeah, they really, depending on a lot of things. And again, I think our guys are like on the forefront of everything. So I kind of am like a fly on the wall, and I listen to it because it definitely changes every time. Not changes. But they are discussing and looking at their studies and their information and constantly collaborating. But I would definitely say between that 6 to 9 month time frame is definitely ideal. And unfortunately, sometimes we do get people much later than that. But then they have a tendon transfer option.
So now we have a whole bunch of cortical reorganization questions. So one just general question before we does cortical plasticity decrease as we age?
Yes, and that was one of the factors that was listed on there. Of course, it can happen, but I think we all see this in all of our clients. Unfortunately, I see it in myself sometimes, just our ability as we age. Just might happen to go a little slower. But again, we know that that's a factor. So with our clients that are in, their 30s, 40s, 50s, and beyond, we are focusing on that more because guess what? Sometimes the younger clients don't need to focus as much because they get it very quickly. They incorporate it very quickly. So that's where I think, having guidelines is great, but really become good assessors of your clients, see what they need. And then now you have tools to know, what do I need to have them focus on?
So Are there some favorite cortical reorganization techniques and biofeedback interventions that you like to use? And maybe even talking about specifically with like the SOMSAC as well as the Oberlin, like what specific activities would you do for those patients in general?
Yeah. So
it's a loaded question.
I am very fortunate. I will tell you, for me, biofeedback has really been a game changer. I know it's not available to a lot of people. Specifically in this population, it has, because I used to kind of be the biofeedback where I would be the audio and the visual and cue that they are seeing some type of twitch. But because we also have amputee clinic, we have a biofeedback machine available to us, and having that visualization, because the loss of cortical reorganization is tremendous in this population, and they just don't know how to get it. How do I activate it? Or when that phase 2 happens and there is a twitch, I still don't know what to do with that, So having that biofeedback definitely is great. Some of those examples I have used a lot, but for me specifically, what I've learned a lot in a lot of these clients is really make whatever you're doing activity-wise with them, find something that they are looking forward to doing. It makes it so much more meaningful than, sit there and passively flex your elbow, while you do this. Why not put your favorite food in that hand and then do it and then passively elbow flex? It makes it a little less monotonous for them, because remember, it's months before they see anything. So at every phase, you have to make it meaningful. Some of the fun things when you talk about like in the later phases, again, a lot of times there's clinic space, equipment that are limitations. So we're forced to become very creative. One of my clinics, thankfully I have a BTE machine. So that was very easy to do, a lot of simulated things. But, I live in North Carolina now. It's a big basketball state. We do a lot of fun sport things. We, grade everything. But I think that really is the key, to keep them engaged as well.
So can you define flooding the recipient as far as like, what are you looking for repetitions, and what are you prescribing for these patients to do? We know we want to try to get as much cortical input to the donor as we can, but what does that look like? Like, what do you prescribe for them for home programs?
Yeah, that is always a question as well. So if you originally look at the DAFRA on stage 1, they want them activating that donor every hour or two, and then passively doing, 3 times a day, let's say. But for me, again, it's all about assessing. So some people, they get stiff. So I might tell them to also passively move more frequently than that. Sometimes I will say, depending on the person, I remember I had a young gentleman that he was a strength and conditioning coach. He was used to functioning at a very, very high level, but he was over fatiguing himself. He was doing it almost ad nauseum every single second of the day. And so I had to really, modify him to not do as much during the daytime, or I will give them criteria. When you are now, let's say in phase 2, you're starting to do place and hold, and after maybe 5 repetitions or 10, you're unable to do that place and hold, just stop. You need to also listen to what that recipient muscle is telling you.
So there's a question then that came up as far as with the recipient muscle. So this therapist was always taught to initiate a contraction, but being cautious with newly innervated muscles to avoid overactivation because it can be damaging. And has that changed?
Yeah, so a lot of it is more like that low intensity versus, I'll use an example again of that one client that was used to functioning at a very high level. He was trying to put resistance and doing all this stuff, with it. And I was like, actually, no, we need to make sure that we're doing low intensity, good quality movements. So what I found early on with some people, that good quality is maybe 1 or 2 contractions. Maybe it's 5, maybe it's 10, you know? So I kind of allotted base on that. But then if you're saying, okay, start with maybe a repetition of 10, 2 sets or whatnot, then you can start with that basis. But I will say that not everybody can achieve that. So but it is important that it is low intensity and not high intensity resistive training.
So when we think about using E-stim, there was a question that came up. Do you use E-stim to prevent muscle atrophy while waiting for that recipient muscle to start activating over that 6 to 12 months, or how do you use it in practice with your recovery phase?
Yeah, so I will say I don't use NMES, and you know, working on a project with a lot of therapists around the world that treat these a lot. None of them use NMES because of the conflicting literature on whether or not that is detrimental to nerve transfers and stuff as well. So I don't, and I don't think a lot of talking with a lot of other therapists that treat these a lot don't use it on a regular basis and opt a little bit more for biofeedback and cortical reorganization techniques too.
Okay, so we have some specific things just about the SOMSAC. So with the SOMSAC transfer, are you also dealing with the weakness and loss of motion of other motions about the shoulder? Or are you just really focusing on shoulder abduction? Can you just kind of describe that a little bit more?
Yeah, so with indications of the SOMSAC, you know, it depends on what they have lost, but really getting them to just be able to raise their arm up to be able to function, and maybe they get a little bit of external rotation as well. That's always a plus, because, you know, when they are reaching forward, they can use their pec as compensation as well. So that shoulder abduction and reaching out to be able to groom or to bathe, that a lot of times is the goal for that, independent on, again, the injury and the indication whether what it is that they're doing it for.
And then a question came up too, that are you also addressing, that sounds like you are, as far as with the postural issues about the overuse of the pec, are you also looking at their rotator cuff and scapular stabilizer weakness during that neurotraining phase?
Absolutely. That's where that watching for compensatory patterns, quality of movement, keeping the things that you know eventually are going to be important in mechanics of the shoulder that you can work on early on. So absolutely, I'm looking at all of that in scapular mechanics, kinetic chain.
Everybody needs scapular stabilization, right?
Yes, right. Yes, and just everything, because the amount of compensatory patterns that these clients present with is significant. So we're almost trying to always keep that end goal in mind, because we know that how do you get them out of that patterning, right? Like once they start to get some deltoid function, it's very hard. So when we talk about what do we work on early on, some of those things I didn't specifically address, but us knowing biomechanics of the shoulder and what is going to need to happen later on, then we address that stuff.
So there's some questions too about biofeedback. Could you provide a good reference for your biofeedback technique? And then there was also a question about the biofeedback unit you use in your clinic, but just really looking at, is there a study that therapists can reference as far as to get the ideal when looking at the settings for providing biofeedback?
Yes, so that is also in your references. And if you go back to the slide on the biofeedback, it's Sturma et al. In 2019, does a wonderful job of outlining how to utilize biofeedback and then also work on selective activation as well. The unit that we have in our clinic is from Össur. Again, because of the amputee population that we see, it's a very, very nice unit. I have also, when I've been at conferences, there have been some smaller biofeedback units. The issue that I've had is a lot of insurances don't pay for it. So, you think about carryover and, compliance and, do we need to see them that often just to do biofeedback when they can get a biofeedback unit at home? Yes, that would be ideal to save some of those insurance visits, right? But unfortunately, I have yet to find an insurance that covers it. So sometimes, getting patients to be able to pay out of pocket for that is very, very difficult. And that's where I struggle a little bit too, with how can I get that cortical reorganization outside of the clinic as well, if they don't have a biofeedback unit. But so it is outlined in that article very, very well. And remember, you use it on the recipient and only when there is a twitch, not before that.
And the twitch, there is a question, is it happening at rest or with movement that you're seeing that twitch?
So the twitch is usually happening when they are activating the donor, and then you'll see it. And I will tell you, it is like it. I can't even describe the feeling of when a client feels. I sometimes have to hold back my tears and act real tough, during the session, but sometimes they just lose it because they haven't seen that move in months. So it's and that's where if you do the isometric contraction to the donor, then you will be able to feel that twitch much more if there's a question of it. Yes.
So a therapist had asked that she or he realizes that each person's different. However, is there a suggested frequency of visits, like weekly for a patient, provided like if a patient only has a limited number of visits, what we all kind of struggle with, or what's the process of explaining like the overall therapy process? Because it sounds like too that this is a long process, so it could be over multiple years. So what's kind of your guideline looking at that, realizing that does vary with the individual?
Yeah, so the phases that that we discussed, and then the kind of the expectation and the goal in that schematic that is in your handout, I will talk with patients a lot on that. Like, okay, this is the process that's going to happen, like in phase one. Sometimes those people I'll check on monthly, just because when I look at that Hills article, or I'm discussing with the surgeons, what's the length of time that I'm expecting to see something? It could be, 6 months, 9 months. So let's say that client is very independent with the cortical reorganization. Their passive mobility is good. Their edema is good. Okay, come back every month and let's just check in. And the great thing about that article and communication with a surgeon is we're constantly communicating the same thing. Around this time is the expectation. You are likely going to see some type of contraction. And it's great because I'm actually in the room with the surgeon. They see I'm there. We're telling them the same thing. Because if someone were to tell you, you're going to have to wait 6 months in order to do this, you kind of lose a little bit of hope, I think, because life does go on. So that's where adjusting that, okay, every month, but I will always leave it open to them to say, if you're struggling with something, call me, let's get you back in, let's have a phone call, let's do whatever, The one thing about this population is always make yourself readily available, even though they may not formally need to be in your treatment, in your clinic at a certain phase. Because then when they do start to get recipient activation, you do see them a little more frequently because now they're starting to incorporate in their daily life, but they've had months of not incorporating it. So but so that's kind of a little bit of criteria and discussions I have with my clients. And also I've had people that they will send to me preoperatively because their joints are so stiff, because maybe they got to them 6 months after their surgery and they do need a nerve transfer, but all their digits are contracted, their wrists are contracted. So those people, I will see 3 times a week sometimes. If I know if that timeliness of the surgery needs to happen in the next month or two, I will for sure see them more often.
So looking at the extended recovery, do you have difficulties? Sorry, you kind of answered that with insurance coverage. Are we seeing improvements after a year? I mean, what is your expectations that you give these patients? So a year out from their procedure.
Mm-hmm. Yes. So let's say with the SOMSAC, for example, when you look at the Hills article, it says it could be 12 months before they get functional movement, right? So a lot of times I am making sure that I am repeating or giving them the same information that the surgeon is, because then they start to get confused and more frustrated if it's like, oh, well, the therapist said this and the doctor said this, and then, you said this article said this. And that's when we really educate them on there could be other factors like your past medical history. Do you have, a traumatic beta? What's your health literacy like in terms of carryover? So that's the part that constant communication as a team, I feel, is important, because expectations can be forgotten too.
So what's the article you referenced when you said the start of the waiting game, that there was the question? Which one really kind of lays that out?
That's the Hills 2019 article. Yes, and it has 17 common nerve transfers with those, I would say, headings. And that's the most questions that I think therapists have, that clients have as well.
So how do you find an experienced surgeon in nerve transfers? That's a question from a therapist looking for if there's a nerve transfer procedure for wrist extension, MP extension. Is there like some kind of a directory to look? Because I know it's not commonly done across the country. It's getting more common, but is there a directory that therapists could look at?
Yeah, so that's a great question, because obviously, I'm on the East Coast and I'm at one of the largest centers, and I know I'm very familiar with a lot of the places on the East Coast, but we do have therapists as part of that team that are from the Midwest and the West Coast. So a lot of the surgeons like mine, the brachial plexus, they have certain tabs even on their websites now that is that if they did brachial plexus centers, a lot of that will pop up and see from across the country, where there's so many more than what there was even 10, 15 years ago, I would say.
Absolutely. I think it's growing, and I think this interest in this recovery is helpful for therapists, because a lot of therapists haven't seen this. So it's great that you're helping to put together some kind of guidelines to know, like, okay, this is what we need to do and when and what to look for. Thank you so much, Jen, for coming in and doing this great presentation on this like up and coming topic for hand therapy. We really appreciate you sharing your expertise, and this will be a great foundation for therapists moving forward. Yes. When they have that SOMSAC procedure. Oh no, what is it? Where do I need to start, and what can I refer to as far as for expectations of what to do next? So thank you so much for joining us. We really appreciate it.
Thanks for having me.
We'll now take a little break, 5 minutes, and then we'll be coming back for our next presenter on relative motion orthoses.
Well, hi, I'm Janine Beasley, and it's really an honor to be here to talk to you about relative motion. It's not just an orthosis. I am just thrilled to be part of this MedBridge group, and I want to thank MedBridge for having me here because they're doing so much for continuing education and really providing quality that can help all of us and our patients. So let's get started on relative motion. I have no disclosures in relation to this presentation. So today, I hope the learning objectives will be that you will apply the concepts of relative motion to an extensor tendon repair, implement the use of relative motion for a specific condition to facilitate improved patient participation in daily activities, and determine the correct digit position in a relative motion orthosis relative to the adjacent digits based on the condition. And I'm going to have some videos where we make some orthotics, and I hope that that will help you to plan to fabricate a relative motion orthosis for a specific condition using a whole bunch of different materials. So let's get to it. Where did this relative motion is hot right now, really hot. In fact, the April edition of the Journal of Hand Therapy, this whole thing is dedicated to relative motion. But it has its beginnings with Wendell Merritt, the wonderful Wendell Merritt, Dr. Merritt, who worked with Sandra Robertson and Maureen Hardy, and they were really concerned about the outcomes of zones 5 and 6 extensor tendon repairs. So as you know, zone 5 is over the metacarpal phalangeal joints, and zone 6 is proximal to that. It used to be that we just immobilized them and hoped for the best. But, and a lot of the attention in the literature went to flexor tendons as opposed to extensor tendons. But more than 45,000 extensor tendon injuries are seen in emergency rooms each year, and zones 5 and 6 are the most common. So what do? Somebody walks in with an extensor tendon laceration that's been repaired. Historically, there was a static protocol. A static orthosis was fabricated. And you can see the PIP joints are left free because they're extended by the intrinsic muscles of the hand. So it was all right to clear the PIP crease and allow the patient a little bit of movement there. Along came Rosalind Evans in 1986, and she said, hey, we're using dynamic protocols with our flexor tendons. How can we apply that to our extensor tendons? And so she recommended a dynamic orthosis, and it is in the middle of these two pictures here, that allowed only flexion to a certain amount and gradually increased that amount of flexion as the weeks progressed. But Merritt and Howell in 1998 introduced the relative motion concept. And this is what has really changed how we look and treat our extensor tendon lacerations in zones 5 and 6. So in 1998, Saldana applied the quadricia effect to the management of extensor tendons. And this can be a difficult concept to understand, the quadricia effect. But if you look at this farmer here on the right-hand side of your screen, hanging onto the reins of 4 horses, if all the reins are taut, there's going to be equal amount of force or pressure on those 4 horses. But if one of those horses has the reins are loose, then that horse will not be in control of the farmer. The same is true with extensor tendons. Pretend those horses are each an extensor tendon, and one of them is in more extension than the other 3 horses or tendons. That will reduce the amount of force on that tendon. Let's make it a little clearer. So here we have a wooden hand that I always have in my office, and I took a piece of duct tape and cut it into 4 strips with a common muscle belly. And here you can see the repair site in the middle finger with a little pencil mark. If I take a pencil and do the pencil test, putting the other digits in metacarpal phalangeal joint flexion, the middle finger extensor tendon, can you see how it's now on slack? There's really no pressure on it as the patient would flex and extend the metacarpal phalangeal joints. This is the concept that Dr. Merritt demonstrated in the operating room with a cadaver. And that's been really the foundation. Relative motion means relative to the other digits, okay? So how do we do this? Controlled active motion following extensor tendon repair allows immediate controlled active motion. The Howell article in 2005 applied this concept not only to zones 5 and 6, but zones 4 through 7. And they were able to allow their patients to return to work with this orthosis in place after an average of only 18 days, which is attractive to our insurance companies. The average time to complete the program was 7 weeks. and the average of only 8 therapy visits. So, another study by Hirth in 2011 demonstrated that using the relative motion orthosis allowed early return to work and improved range of motion in 23 subjects. The advantages, as you can imagine, compared to immobilization, is it's small, it's simple design, it's simple patient instructions. Just do gentle MP range of motion, but keep the orthosis in place, allowing earlier mobilization, a little bit of functional use of the hand. Now here you got to be cautious. You got to be sure they're not like lifting very, very heavy things, but just a little lightweight, light activities of daily living were recommended. So Buehler in 2023 demonstrated, they did a study that looked at relative motion orthosis versus dynamic orthosis, as you saw in the earlier slide. This was a randomized control study, one of the strongest types of research that we have, with 37 participants. And they had the relative motion orthosis. They also included a wrist orthosis. And I'm going to talk about that in the next slide. At nighttime, they put them in a static extension orthosis, both groups, and they had similar outcomes. But Shaw in 2023 did the systematic review of all these articles, popped them all together, and they really demonstrated that relative motion is safe in zones 5 and 6. But this third bullet point is the kicker, and that is surgeons are reluctant to use it. You may find that you really have to convince a surgeon with these articles that are in this PowerPoint and in the Journal of Hand Therapy that this is a safe and effective way to go. So you may be asking, what about this wrist orthosis? Do we have to pop that baby on? Well, Merritt in 2014 originally used the wrist orthosis for the first 21 postoperative days. The wrist is in like 20, 25 degrees of wrist extension. And then after 3 weeks, they used only the relative motion orthosis. But Berry and Neumeisser in 2008 used only the relative motion orthosis and demonstrated there was no ruptures. So I had the honor of presenting this topic with Dr. Wendell Merritt at the American Association of Hand Surgeons, and he said they're no longer using the wrist orthosis anecdotally. So how do you do this? Well, the repaired digit is put into 15 to 20 degrees more extension than the digits relative to it. For example, here, let's look at the right-hand side, the long finger, the middle finger. Here you can see the middle finger is in 15 to 20 degrees more extension than the index or the ring. On the left-hand side, here the index digit has received the injury and repair. And so that digit is held in 15 to 20 degrees more extension relative to the middle and ring finger. Here, though, in Merritt's article, they discuss adding the little finger as a yoke. A yoke used to be the term for the relative motion orthosis, but it's evolved over time to be RMO. But you may see yoke in the literature, and it does. It looks kind of like a yoke between two fingers or two oxen or whatever. But here it would just add a little balance. So here's a little video that we're going to start. You can go ahead and start the video. And let's see here. Can we start that video? And what we have here is the trick. The best trick that I can give you today on this Saturday is to use a pen, okay? You put a pen, the digit that you want to be held in more extension. And this allows you to not have the horrible thing happen that the middle finger or the involved finger droops down at the very last second, which is totally frustrating. So you're going to, this is Polyform. You can use a variety of materials. And you can see how I've removed the pen briefly, but then I put it right back in at the distal to the PIP to hold that middle finger, the involved digit, in more extension relative to the index and the ring. Here I'm working hard to clear the PIP creases of the digits and to close the door on these different on the splint on the volar surface. Excuse me. You can see that Polyform is a very nice material. There's many that work really well for this, but it allows a great deal of moldability. But can you imagine, without the pen in place, you're going to have to really keep track of keeping that middle finger in more extension. This just changes your life as a splinting person. Helps make it very, very easy to do. And but you want to be sure you get that between about, that 15 degrees of extension. Now, I also like to close the door. I like to add a dorsal Velcro strap, because right now the Velcro, the finger's just kind of loose. This is not in all of the articles I read. This is just something that I feel more comfortable that the digit is secured. So this is just my little thing here. And you can see how the patient can move at the PIP joints and at the MP joints. And you always just be sure, as it sets up, those final moments, pop that pen in to make sure you have maintained that extension, other than the other two relative digits. We're going to go on now to the next slide. Okay, here it is, the one that I just made in the video. You can see from the lower slide that the middle finger is 15 to 20 degrees higher at the metacarpal phalangeal joints. And also, we clear the PIP creases, and a little Velcro up in the upper left-hand side just kind of sets the digit in place. Okay, what's the postoperative protocol here? According to Howell, first 1 to 3 weeks, full-time relative motion orthosis with the wrist orthosis, although most protocols are getting away from that. 4 to 5 weeks, active range of motion in the relative motion orthosis only. And then they also start combining wrist and digit flexion if there's no lag, and weaning from the wrist orthosis if that hasn't been done already. And then at 6 to 7 weeks, you get full composite active range of motion outside of the relative motion orthosis. So it's just a delight, I must add, to have those that's much simpler protocol for these patients. So I hope that you, in Chapter 1 here, have understood that relative motion has been reported to be safe and effective for the management of zones 5 and 6 extensor tendon repairs. And I hope that you can apply these concepts and determine the correct digit position relative to the adjacent digits, and are ready to fabricate a relative motion orthosis for extensor tendon repairs. Okay, so we're going to go on to Chapter 2. So relative motion with extensor tendon repairs has been done for quite some time, but there's some other areas that are showing up where relative motion is relative. That's going to be my joke of the day. Okay, let's look at the extensor tendons. The extensor tendons flatten as they get closer to the metacarpal phalangeal joints, and the sagittal bands help keep the extensor tendons right in the middle of those joints. So when there's a sagittal band injury, the resting subluxation of the extensor tendon can fall into the valley, typically the ulnar valley of the metacarpal phalangeal joint. The middle and the ring fingers are most common, and the tension is also changes at the junctura tendinum, contributing to the ulnar subluxation of the tendon. Let me explain that a little more deeply. So there's a link between the extensor tendons with the junctura tendinum, and they redistribute the force and the spacing of the extensor digitorum communis tendons, reducing the excessive load on the sagittal bands and help to stabilize the metacarpal phalangeal joints. So when there's an injury, that tendon, you can see it just pop, just go right into the ulnar valley. And these are so painful. People are very, very grateful for a relative motion orthosis. It can really be treated conservatively with the same concept. It helps to maintain the extensor tendons over the midline of the MP joints and reduces the load on the sagittal bands and the junctura tendinum. So the concept, remember, relative motion is more than an orthosis. It's a concept. You want to place the MP joints in 15 to 20 degrees more extension than the digits relative to it. You're going to, it'll be worn for about 6 to 8 weeks. Some of the physicians report that they want to immobilize it for about 3 to 4 weeks before starting relative motion. Others are using relative motion right away. And I think if you're seeing this in the clinic, it's an easy thing to let's take a pencil and try it, and see, does this decrease your pain? Okay, maybe it's time for a relative motion orthosis. So, okay. So let's take a look at that orthosis. We can start that video, it's a very short video here. You can see how here we have the middle finger, and all these videos, I have only done the middle finger, just so you could orient yourself. But here, the sagittal band, it's only between the index, middle, and ring finger. The middle finger has the extensor tendon drooping or falling into the valley. And so you only need to really do this with the three digits. It's small, it's easy to wear, and the pain dramatically decreases. Also, you can see on the slide, and I want to thank you for playing that video again. That was very kind. Sometimes swelling is a big issue here. So if I seal the orthosis, you can see on the slide on the right that it may not accommodate changes in swelling. And so leaving it open so that they can make it a little larger or a little tighter with a Velcro strap can be very helpful. This splinting material is, of course, different than Polyform. It's Orthocast, and it's very soft material, and patients like that as well. Each has their advantages and disadvantages. So that is sagittal bands. We're going to move now into boutonniere deformity, acute and chronic. Yes, relative motion is relative to boutonniere deformity. I have to tell you, I got asked to present on the boutonniere deformity in Paris, France. I couldn't believe I got the opportunity to do that. And I said boutonniere deformity, my only French word. And in France, they say buttonhole. So we say boutonniere, and they say buttonhole. Anyhow, moving on. Boutonniere deformity, trying to keep you awake on this Saturday. Acute and chronic. Typically, when you have a chronic boutonniere deformity, and boy, oh boy, do you see that. Isn't someone coming up to you knowing that you work in hands and saying, I've got this finger that I can't straighten all the way. And so often they were an injury, a sports injury. They never got it fixed. Oh, it's just jammed. It's no big deal. And they end up with a boutonniere deformity. And months later, they can't extend their PIP joints. So they come to us and we serial cast them and get them out into full PIP extension as much as we can. I miss Quick cast, everyone. On the left is quick cast. They don't make it anymore, but we do have some alternatives. But you can see how both a chronic and boutonniere deformity, it's PIP flexion, DIP hyperextension. And so as you correct the PIP extension, be sure to look at the DIP flexion. And that's why on the slide on the bottom right, I like to add a little lip, a little to the tip of the DIP there so that they don't fully extend that DIP. Burton has classified boutonniere deformities into 4 areas, and that is stage 1 is supple, passively correctable. 2, you've got a fixed contracture with contracted lateral bands. The joint is still okay. Stage 3, we start to get volar plate and collateral ligament contractures with intra-articular fibrosis. And then stage 4, this is the hardest. It's you have all of that plus proximal interphalangeal joint arthritis. And so as the joint gets involved, you're no longer really dealing only with soft tissues, but you're dealing with joint damage. Okay, so here we go. We got an acute boutonniere deformity. You are seeing a patient who just entered their boutonniere. It hasn't been 6 months, and you notice that when you do the pencil test, remember the pencil test, all it is you're going to put the pencil in place and see if they have full PIP extension when you have that middle finger in more flexion relative to the other digits. And if they do, they are a candidate for a relative motion orthosis. And they can wear it for about 6 weeks during the day. But at night, a static orthosis is recommended according to all of these authors here, including the fabulous Dr. Wendell Merritt. So remember, greater than 2 months though, they probably do not have full PIP extension passively. So you've got to start by serial casting them until you can get them up to at least minus 20 degrees. And if you can't get them to minus 20 degrees with serial casting, now here again we have Orfit. You should allow DIP range of motion too with your serial casting. Remember, DIP range of motion gets those bands, lateral bands up where they are drooping down and causing that PIP flexion contracture. But if you're able to do it, then you can move them into a relative motion orthosis. Okay, if you want to play the video here, that would be lovely.
So for boutonniere,
and I just wanted to show you a little concept with the nighttime orthosis here. So you can see that I got them in full PIP extension, and I have them wear a night orthosis. And you can see the night orthosis has that little flexion, and you can encourage them at all times, though, to do that DIP, active range of motion, but trying
the lateral bands
to prevent nighttime, full-time DIP extension.
So that's a nice orthosis.
I like to go dorsally. You've probably noticed this at this point. I'm a big dorsal splint person. I believe strongly in this, and therapists throw food at each other about this. But I have to tell you, dorsal is easier to manage because you can you have more leverage, and also you have more space for all these little Velcro tabs. And you can see how I like to cross them over, have them be double, so there's a lot of Velcro in contact with the orthosis, not just a little bitty spot. Okay, so in the literature, though, the use of relative motion orthoses for chronic boutonniere deformities, it's pretty good. This study, though, you got to be careful. They said chronic boutonniere deformities, but all of these patients in the Arzian study, they had full PIP extension with the pencil test. So here in the left-hand corner of your screen is the pencil test. These patients could passively extend when the other digits were held in more extension than the involved digit. And so they then put them in a relative motion orthosis. And they had these types of results. They went from a PIP extension lag of about 22 degrees on average to 12. And look at what happened with the DIPs as well. The DIPs only had 47 degrees going in. They went up to 66 degrees. This is a good orthosis for chronic boutonniere deformities if they're passively correctable with the pencil test. So there are lots of different materials you can use. I don't work for any of these companies, so I use a lot of different materials, but there's Polyform. There's also a prefabricated option, and this is called the hook splint, which is available from one of the vendors. There's Orphicast, which you've seen a lot of, and we also have a new material called UCast, which is made up of natural materials and is biodegradable for your carbon footprint. So I'm not saying one is better than the other. I think we as therapists feel strongly about our splinting materials, but the concept of relative motion transcends all of these materials. So this is the hook splint. That is the prefabricated option, and you wrap it around and adjust it. And here for the boutonniere deformity, it's holding, again, that middle finger in more flexion relative to the other digits. So, and if we could start that video, that would be fabulous. Look how fabulous. They're just so nice to work with here at MedBridge. And so here I'm doing my pencil test. Whenever you make an orthosis with relative motion, get that pencil or pen involved because, well, it's going to prevent that last minute leveling of the playing field. You've got the one finger in more flexion and then all of a sudden it pops up at the end. And so this helps you to prevent that. So this is Orphicast, and you can see that I am folding it into thirds, closing my edges. And now I remove the pen slightly, but gosh, I am oriented now. I know exactly where it is because I had that pen in place. See, it does help the therapist fabricating this. It's like, okay, which is up, which is down, which is over, which is out. Easy to do because the pen reminds you. Then I move the pen down to the distal to the proximal phalanx, and here I'm only concerned about the middle finger boutonniere deformity. I don't have to do all the digits. And so I'm working hard to close that door. And you can see how the MP joint is in more flexion than the index and the ring. And the pen helps me to do that. I call it just a little bit of magic there. So do that. And now, it's that last second, though, that you can lose it when you're making this orthosis. So if you take the pen out, be sure that the material has set up, and I see my thumb is protecting the position there with that. So we can go on to the next slide. Very good. Okay, so remember, with chronic boutonniere deformity, when do you begin relative motion? That's going to be, you're going to serial cast until you get full PIP extension and DIP full active flexion, and then you'll begin relative motion for an additional 4 to 8 weeks with the night PIP extension orthosis. A little note, I'm sorry, on this dorsal or splint, I like to draw a fingernail right through the Velcro here so the patient knows exactly where to put that puppy, you see? So draw a little fingernail on the Velcro and they won't get it upside down, sideways, and inside out. So very good. So I hope that this chapter 2 here, you were able to apply the concepts of relative motion for sagittal band injuries and boutonniere deformities. You understand the correct digit position relative to the other digits, and you observed how to fabricate a relative motion orthosis for both sagittal band and boutonniere deformities using different materials. So we're going to go on to the final chapter, and this is going to be relative motion concepts and orthosis. Yes, ladies and gentlemen, with flexor tendon repairs. Can you believe that? Digit stiffness and other conditions. Okay, so we've been talking with extensor tendon repairs. we have some really good literature. We've got a systematic review with flexor tendon. We just have a little bit of literature. So this is very new, and I just can't say that everyone's jumping on this bandwagon yet with flexor tendon repairs. But as you know, this is an audience of people that work with hands. The big dorsal blocking orthosis that is worn. With the Manchester orthosis, the wrist is free. But here we're applying the concepts of flexor tendon repair to relative motion. And that would be, here the little finger has received the flexor tendon repair, and you would hold it in more flexion relative to the middle ring and long finger, to the other 3 digits. Here again, you can see there's a lot of swelling with flexor tendon repairs, so you hate to have a closed system. So being able to pop open that seam and apply Velcro on the right-hand side, you can see that the patient can adjust this for swelling. So what happens? The relative motion for flexor tendon repair, the MCP joint, is placed in more flexion than the other digits. Flexor digitorum profundus shares mostly a common muscle belly. Now the Quadritia effect, just like with the horses, all 4 horses, if the reins are a different length, that you're going to limit the excursion of the tendon. It offloads the repaired tendon. Also, with flexor tendons that the IP joints, the intrinsics, when you put the digit in the MP joint, as you know, in more flexion, the IPs have better extension. They have better excursion, just as we were talking about with the boutonniere deformity. So this can be a bonus of using relative motion with flexor tendon repair. Currently, everyone is using a wrist orthosis in about 0 to 20 degrees of extension to lower the amount of work that those finger flexors need to do. And Chung in 2019 did a cadaver study showing that relative motion orthosis reduced tendon elongation and gapping right at the repair site when the MCP was held in 15 to 25 degrees more flexion relative to the other digits. So the flexor digitorum profundus for the ulnar 3 digits share the same muscle belly, but sometimes there's a variation, and the index muscle has a separate muscle belly. So most of the people using this protocol are not doing it if you've received a flexor tendon repair to the index digit, just in case they have that variation. But you can see this on yourself. You can do DIP range of motion, active range of motion, where it's harder to do in the ring finger when there's the common muscle belly. So anyhow, Newington in 2003, they had 18 patients. They put the MCP in 30 degrees more flexion, full time for 5 weeks, with a prefabricated wrist orthosis in 15 degrees of wrist extension that they wore for the first 3 weeks. But they had 2 ruptures. Ouch. One for the index and one for the small. So you may want to think about that. And I'm kind of waiting for more studies to come out on this before I jump on this bandwagon, but it's here. Where it does shine, though, is with partial flexor tendon injuries. With a partial flexor tendon repair, it's hard to put an individual sometimes, at least it is for me, in a big dorsal blocking orthosis, because it's like, oh, it was a partial, is it going to rupture? Probably not. So they used the relative motion orthosis for a partial. It was the middle finger of the left hand. This is one case. Again, the literature is sparse, but here you are at MedBridge learning the latest stuff, you see? So this is the newest information on this. the middle finger had a 60% laceration of flexor digitorum superficialis and 90% of flexor digitorum profundus. Also had a digital nerve laceration. They used this relative motion orthosis for 6 weeks. The first 4 weeks, they did active range of motion in the orthosis, and then the 4 to 6 weeks, they took the orthosis off for combined digit wrist extension and flexion, but they wore the orthosis between the exercise sessions. So here's a video, if you don't mind starting the video on. If you and your surgeon agree that you want to try this with a flexor tendon repair, you would get a prefabricated wrist orthosis, or you could go ahead and make your own. It is a little time saver to have a prefabricated one. And here again, a pen or a pencil is your best friend. I hate to keep repeating that, but you want to be sure to hear the 5th digit is now the one that has received the injury to the tendon, the flexor tendon. So take the this is Orphicast, and I folded it in thirds upon itself. I remove the pen, and then I'm putting the 5th digit in more flexion compared to the other digits. And you can see how I'm closing the door. And it's a little finger. The little fingers are difficult, let me tell you. But you can get that right there. So, and you want to really press it in place. Now, I'm going to go back later and open that door because there can be swelling, and I put a little Velcro tab there. But if you don't have a lot of swelling, you can make it a solid piece. Again, I want to have a good formation between the digits. I like to have a little divot between each digit, and I want to be sure that I clear the PIP creases volarly. So you can see that I have with each of the fingers here. And that allows that they can actively flex those PIP joints and the MP joints, but they're constantly using the relative motion concept to protect the repaired flexor tendon. So I'm going to go on to the next slide. Very good. Okay, so another area I know you might find this surprising is trigger finger, but this is expert opinion only. So here we have, can you use relative motion with trigger finger, you may be asking? Well, we have such wonderful research with trigger finger. The MCP blocking ring splint. Now, trigger finger, if you partially restrict the excursion of the flexor tendon, you can really take care of trigger finger in 73 to 92% of the cases. This MCP blocking ring splint in the top left picture is just highly accepted by patients. It's small, it's easy to wear, it restricts the excursion of the flexor tendon, and according to the study by Colborn, 92% of the symptoms were resolved in 6 to 10 weeks. The first study, as you know, is the photo on the right, the hand-based volar orthosis, which was Evans in 1988 demonstrated a 73%, I like to call it a cure rate for trigger fingers, because she was just started this whole thing going, limit the tendon excursion, you can reduce the symptoms of trigger finger. So that's the concept. The concept is limiting the excursion. You can also do that with relative motion. And you can see how you would have the digit in more extension than the relatively to the other digits. So in the bottom two slides, they both have the middle finger in more extension relative to the other digits, limiting full tendon excursion, which is what the other trigger finger orthotics tended to do. Now I have to tell you, if it's me and I have a trigger finger, I think I want the smallest orthosis possible. I may go with the MCP blocking ring splint, but the concepts of relative motion can be applied here. Okay, mallet finger. Boy, this is where we spend our days, don't we? Treating mallet finger. And you can see on the picture on the right, yes, it is the DIP, but the PIP can also run into hyperextension issues. And so you may want to think about a relative motion orthosis to keep that PIP in more flexion. So here on the right-hand side, we've got a relative motion orthosis, keeping the index digit in more extension relative to the middle finger, and the little, whatever mallet orthosis you elect to use, which is always, that's a whole nother lecture, mallet splinting, oh my goodness. But relative motion can be really helpful to that situation. Digit stiffness is another area that is really where relative motion shines. It's so effective. For example, here on the left, if you want to increase PIP extension of the middle finger, well, you put that middle finger in more flexion relative to the other two digits. And just as we learned with boutonniere deformities, it's really going to facilitate increased extension of the PIP joint as the patient flexes and extends. The reverse is true as well. You would like a little more MP flex or PIP flexion. Well, place that MP joint in more extension relative to the other digits, and it's going to facilitate PIP joint flexion. It's just really a nice technique for increasing range of motion. Some are recommending it, the relative motion orthosis, for rheumatoid arthritis. Now, I think it's really, although it's relative to the other digits, it's quite different in this concept. For example, if you have, let's say, a nicely aligned index digit with, here's the zigzag deformity on the right, but let's say the index digit was nicely aligned, the other digits were not, you would then have an alignment orthosis to help hold the digits in alignment as you see on the bottom left. Or for example, the little finger, let's say that was severely ulnarly deviated and you wanted to bring it over towards the ring finger, the splint that I'm showing here on the left would help with that. I think that it is kind of a different concept than what we've been talking about this morning as far as extension and flexion. It is that alignment. But it really applies with rheumatoid arthritis when there's a sagittal band issue. You see, as we talked about sagittal band issues, this is really helpful to the rheumatoid patient when they're subluxing into the valley between the metacarpal heads. So this is really individualized, but I wanted you to know that you may be hearing about that. So in summary, I hope that this chapter was helpful in applying the concepts of relative motion for a variety of conditions, and that helps you to improve patient participation in daily activities, understanding which digit position, which is higher, which is lower. And I hope that the videos were helpful to you so that you can make these in your clinic Monday morning. So there we go. So it looks like it's time for questions and answers.
Thank you so much, Janine. That was wonderful. We love the videos. It was great. So we have a lot of questions just related to the fabrication for different of a relative motion orthosis for different issues. So I'm going to start with that. Then we have some things specific to extensor tendon repairs, and then some of the other things you discussed. So do you have any tricks to get the right length of the thermoplastic material when you're fabricating that?
Right. Well, it would be, I like to start with 2 times the width of the metacarpal head. So I start there, but all of the materials that I use have a little stretchability. Okay. So I usually I go long and cut them off, you see. So, but a good rule of thumb is to go 2 times the width of the hand. So
what about suggestions? There were several questions about older patients that have fragile skin and that maybe can't tolerate the relative motion orthosis for the duration when we're thinking about like for a sagittal band subluxation. Do you have any suggestions or tips or type of material that works better than others when you're dealing with someone with more of that fragile skin?
You have to be so cautious. Some of these patients, before they were on the advent of biologics, they were on prednisone for a long period of time. Their skin is just like paper, and so I think you're going to want to use. You think, oh, let's make it as small as we can, but you really want to distribute the pressure broader, and also be really careful of your edges. You may find that Orfacast is softer for some of these patients. And so, but if they can't, then I think I would, putting padding on that is going to be a smelly thing. I would put stockinette and then the orthosis so that they could have a fresh, clean stockinette, which is going to be tricky to do with the in and out, but where they seem to be having the most irritation. They do really like it, though. I have to tell you, it decreases their pain, so they want to wear it, but it is a little bit of back and forth, trying to get a good fit. So don't just put it on and say, have them come back to the clinic and reevaluate that orthosis to be sure there are no skin issues.
So one of the therapists commented that she loves using that relative motion orthosis for patients with frail skin in the web space, making sure that when they have to wear it full time that she uses Taylor, Splint, or Orfacast. But do you have any other suggestions as far as with wearing times when you're using it for that sagittal band involvement?
Great. Now, we can use nighttime as, to alternate between daytime and orthosis and nighttime orthosis. So you could have just a simple volar orthosis at night and then the relative motion orthosis during the day. So that's going to unload the skin for at least 8 hours. Hopefully they're sleeping. Maybe they're not sleeping 8 hours, but they're at least, have a different orthosis for 8 hours. Remember, those older patients are getting up in the middle of the night to go to the bathroom. So you want to be sure that it's something that they can manage those activities living as well. And so a nighttime orthosis would just, work at the metacarpal phalangeal joint area so that they could still have their thumb and index finger to manage those important tasks.
So when you're fabricating a relative motion orthosis for an index or a fifth digit, how would you do that? Would you do the bridge where you do both the index and the small together, or what would be your recommendation in those cases?
Yes. Well, Dr. Wendell Merritt, I actually got to talk to Dr. Wendell Merritt about this. I was so honored. They if the index or the small is involved, they do both because they feel it adds balance to the two. And so
I think it also then doesn't tend to tilt. You don't have to worry about that when you think about that ulnar direction of the rest of the hand.
Yes. Yes, I think it's more of a problem if you just do one or the other. So it does provide a little bit of balance, but you're really still using the relative motion concept in that the little finger, if it is involved, the ring finger relative to it is in more flexion or extension, and the index as well. So, but it just provides balance to the yoke. And I kind of think of like the yoke and two oxen, you know what I mean? You've got a nice balanced yoke on this as opposed to one that tips off to the side.
Have you had success then too with more of like the teenage patients with sports related injuries when they have a sagittal band injury to their small finger, using that same concept of doing the index and index and small together?
Yes, and the small finger is the tricky one. It really is.
For many reasons. You talked about
it's
with
so
the flexor
hard.
tendon.
So hard.
Okay.
Get that. Yes, I'm sorry.
Oh, no, that's okay. All right. So with extensor tendon repair, so their question came about several times. Can you just explain the rationale why it's safe to leave the PIP joint free when you're talking about a zone 4 through a zone 7 extensor tendon repair?
Very good. So extensor digitorum communis terminates and the intrinsic muscles. Oh, I need illustrations. Intrinsic muscles, the dorsal interossei, palmar interossei, and the lumbricals, they charge in and they extend the PIP joints and the DIP joints through they go through the lateral band, they go through everything and extend it. So your extensor digitorum communis is not extending your PIPs and DIPs. I have to tell you, when I finally figured this out is when I had a replant. I had a patient whose arm was sawed right off in the mill up north, yeah, and they put it back on, and she had her flexors and extensors, but she had no intrinsics because they hadn't begun to work yet. And this was her range of motion. Okay, this is all that she could do in regards to flexion. She could not extend her PIPs. You see what I'm saying? So when the lumbricals are involved, the ulnar nerve is involved, and the dorsal and palmar, they're doing the extension of the PIP joints. So it's safe to leave them free.
So can you revisit the use of a relative motion for extensor tendon repair regarding the wrist-hand orthosis? Are you using it or not? And then are you placing them in a different type of orthosis at night, or are they just staying in the relative motion orthosis with or without the wrist-hand orthosis?
Okay. Yes. Okay. Again, I really wish Wendell Merritt was here today, because I asked him all these same questions that you're asking. What a great audience we have here today. So they started out, this was a big deal back then, to tell all these surgeons who are still reluctant to do this, hey, we're going to use relative motion. We're not going to use what you've been using for decades. And so they said, okay, we'll be super safe. We'll have a wrist orthosis and the relative motion orthosis. And then those other studies came out and said you don't need the wrist orthosis, okay? So the literature is pretty clear. You just need the relative motion orthosis. What you're dealing with is an anxious surgeon, okay? And so you might want to have the wrist orthosis until that surgeon says, my goodness, this is effective, and then get rid of it. So does that make sense?
Yeah, so more of it is just like from the surgeon standpoint, adopting the new literature that you really don't need to have the wrist portion. Yeah, kind of similar to what we saw with some of the wound care things as well.
Oh, yeah.
So, yeah.
Same. But I usually would present the hard copy articles to the surgeon and say, hey, this was so interesting, or I went to a conference, or I saw MedBridge, and those articles that are all in the references, and also the Journal of Hand Therapy in April here is all relative, the whole thing, relatively speaking.
So for an extensor tendon in repair, for either an isolated middle or an isolated ring, do you just include the digits on either side, or do you include all the digits, the index through small finger, when you're making that relative motion orthosis?
So for the middle finger, include both of them. I would include all of the digits, but I do have to tell you that there's a little controversy with the ring finger. Have you heard about the controversy with the ring finger? So
do tell, please do tell.
So in the original article by Wendell, they put the ring finger and the middle finger in extension together, and I really question that because the relative motion concept. So it's published that way. But all the therapists that I have talked to, and including Dr. Merritt, felt that it would be okay to just have the ring finger in extension. So that is what I see. You're hearing it here, folks. You're hearing it here. So it first came out that they did that as they were worried about balance and with the other digits, but with the ring finger, have that in more extension and including them all. I feel strongly it's important. So.
Okay, so for sagittal band injuries, would you fabricate a relative motion orthosis for the thumb, or can the sagittal band injury occur in the thumb as well? Have you seen that?
I have not seen that. Have you seen that, Ann?
I have not either. Actually, I was like, this is a really interesting question. I haven't personally.
Because if you haven't seen it, Ann, and if I haven't seen it, we have got to talk to this person who had this question. But I would question if there's something else going on with the thumb, more likely osteoarthritis.
I'm thinking CMC issue too. Yes.
Yeah. So, which I'd love to talk about. That's my favorite topic as well. So, but the collapse of the thumb, because the thumb has really no digit that can be relative to it. It is relatively alone in this.
It is with that rotation. Yeah. Okay. All right. Thank you for that. So now we've got some serial casting questions. So how long do you leave the OrthoCast on before cast changes? How many times a week do you have the patient come in, or how often? And can they get this wet with using OrthoCast?
Okay. So I have to tell you, we had a sad day when we lost QuickCast.
I have to say too, I love QuickCast. I loved it, and I like using OrthoCast, but I really miss QuickCast. Yeah. I agree.
And I think we should all pick it or something. There's a whole story about how we lost it, but and that was when we could get wet. With QuickCast, the patient could get wet, and they wore it. I remember with QuickCast, I had like hockey players, like professional hockey players, that I taught the trainer how to do it, and and they changed it like 3 times a day. You know what I mean? And what a joy to be able to change it 3 times a day. Banquet workers, it was great. They were wet, and anyhow, insurance is really limiting us. In a perfect world with serial casting, since they can't get it wet with OrthoCast, you can, but it takes a really long time to dry. It's hard for the skin to be wet that long. As you know, just with a Band-Aid that wet that long, it's not so good. But with OrthoCast, I would like them to come in a couple times a week, 3 times a week in a perfect world. But insurance and co-pays and all of that, it's very difficult to have people come in, and I think that's what the audience is reacting to. Serial casting is very effective if we can do it, but many times we only are reimbursed to do it once a week, and that gets really hard. Are you finding that in the clinic, Ann?
Yeah, I am seeing once a week is the most I can have for them to come in. We have so many questions, and unfortunately our time is out, but it was wonderful having you and giving your presentation and help us to use this for many different things, not just the traditional ICAM program for extensor tendons. So we're now reached the end of session 1. And as additional reminder, remember there's 2 sessions to this summit. So the second session is part 2 of 2, Hand Therapy Virtual Symposium. To be eligible for that CEU credit, participants must register, attend, and complete both sections in full. And everyone's required to do the learning quiz and post-webinar survey, and that'll become available after attending both parts. Partial credit won't be given. The link to register for part 2 of 2, if you haven't done so already, can be found in the resources section of the part 1 webinar console or in the email you received upon registering. I want to thank Janine for this wonderful presentation, as well as the other great things we've had this morning. It's been a wonderful morning. We're going to be taking a break now for 10 minutes, and then we're going to be coming back and we're going to be learning a little bit more about elbow instability.